A very warm welcome to the first international conference on ivermectin for COVID. If this wasn't a virtual conference, we would be in a very large conference hall, as today we are expecting a full house with almost 1,000 delegates from over 35 countries. Thank you so much for signing up. We have put this conference together in a very short period of time, and this is a reflection of the urgency of the matter at hand. Medical doctors from all over the world who have been researching and also prescribing ivermectin to their patients during this pandemic need to share their experiences in order to raise awareness and inform colleagues and decision makers. I would like to make it clear from the start that neither the Bird Group nor any of the speakers have any financial interests in ivermectin. Our common goal is the same as yours, which is to help save lives. All speakers here today have freely given up their time to this end. We are honored to have Dr. Mobeen Syed with us, who has graciously agreed to chair this conference. Dr. Been, as he is known amongst his large fan base, trained as a doctor, and after practicing clinical medicine for a few years, he continued his studies in computer science with the goal of merging innovative technologies and healthcare. Dr. Been's dedication for teaching began at Horizon Medical Institute. His dedication to innovative and pioneering medical education has been the mainstay of his life. At Dr. Been Corp, he strives to create a managed marketplace for medical providers that enables them to learn medicine in conjunction with new technologies. And his YouTube channel has over 280,000 subscribers. Over the past year, Dr. Been has worked hard to analyze and share the most up-to-date evidence on ivermectin through more than 50 YouTube tutorials and interviews with experts. Without further ado, I will pass the baton to Dr. Been, who will start the proceedings with a presentation on the mechanism of action of ivermectin for COVID.
So thank you very much, Dr. Lawrie, and thank you very much for hosting this conference, for sponsoring it, for making it happen. Thank you very much for all the panelists who are here as well. So today, just a quick structure for the conference itself. What we will do is, in the beginning, I'll present the discussion of the ivermectin and its mechanism of action. After that, we would have a few speakers with us as well. So Dr. Lawrie, you yourself are here. Thank you very much for this. In addition to you, we have Juan Chamie, who would be here as well. Juan is a senior data analyst who has been tirelessly researching and spreading the word for ivermectin since May 2020. Like the rest of the world, Mr. Chamie closely followed the spread of COVID-19, and his interest in ivermectin was peaked when the doctor in Dominican Republic used the drug successfully to treat the illness. Quickly thereafter, a major outbreak in Ecuador, Peru, and local health officials successfully used ivermectin to curb the disease. That launched Juan's months-long investigation into the widespread efficacy of the drug. Using data as his compass, he has showcased his result in stunning data visualization. So today we would hear from Juan as well. In addition to him, today we would also hear from Andrew Bryant. He is a biostatistician with experience in clinical trials and systemic review methodology based at Newcastle University. So we'll talk more about him as well, and we'll hear from him as well. Then we'll have Dr. David Chesler as well. And just very quickly, are you able to hear me?
Yes.
So I'm seeing some comments. All right, so good. I see some comments that folks are saying there is an issue with the sound. Good, so we'll have Dr. David Chesler as well with us. He practices internal medicine. He's a physician, private practice. He's been doing that in Charlottesville Family Medicine since 1980. He's a diplomat of American Board of Internal Medicine, board certified in geriatric medicine. Tomorrow, you would be really happy as well. Just like today, we have star-studded day tomorrow. We'll have Professor Eli Schwartz from Israel, and we'll discuss his bio, his his beautiful work as well. So he's a director of the Center for Geographic Medicine at Sheba Medical Center in Tel Hashmor, Israel. First introduced the field of travel medicine in Israel. His practice became the recognized center by the Ministry of Health of Israel for tropical and travel diseases. Dr. Schwartz is currently serving as the president of the Israeli Society of Parasitology and Tropical Diseases and past president of the Asia Pacific Travel Health Society. He's a full professor, clinical, at the Saker Faculty of Medicine, Tel Aviv University. So we'll hear him tomorrow. With that, we will hear our own beloved and the hero of this with Dr. Lawrie, Dr. Pierre Kory. So Dr. Pierre Kory is a board certified in internal medicine, critical care, and pulmonary medicine. So 3. He's a former chief of the clinical care service and medical director of the trauma and life support center, while an associate professor at the University of Wisconsin. Prior to this, he served as a program director of a pulmonary and critical care fellowship training program at Mount Sinai, Beth Israel in New York City. Dr. Kory is also considered a pioneer in national and international expert in critical care ultrasound and is the senior editor of the best-selling textbook on the subject, which is in its 2nd edition and has been translated in 5 languages and has won the President's Choice Award from the British Medical Association in 2015. Dr. Kory is also considered a master educator, which you would witness, and has won multiple major departmental teaching awards at each institution that he has served as a faculty. With him tomorrow, we'll also have Dr. Wasif Khan. He is enteric and respiratory infections specialist, infectious disease division, International Center for Diarrheal Disease Research, Bangladesh. With him, we will have Dr. Hector Carvalho from Argentina, Nati Professor University, Iberta, Interamericana, Argentina, ivermectin, and carrageenan in the prevention of COVID-19. Professor Carvalho is former professor of medicine at the University of Buenos Aires. I'm hoping I'm pronouncing the names correctly. If not, please forgive me, as well as the former director of the Aziza Public Hospital in Argentina. Currently, he is involved in the development of strategies to defeat SARS-CoV-2. And in general, you would see all the folks who are here today, the participants as speakers, they have an interest to make sure that we can come out of this pandemic, this situation, with better outcome for humanity, and has been a vocal advocate of ivermectin. Recently, he was appointed as the editor-in-chief of the newly released OAJ Research and Applied Medicine. With him, we'll have tomorrow Dr. Tina Pierce. Dr. Tina Pierce, with a background in general practice, became a consultant in contraception and reproductive health in 1996. She then led the contraception and sexual health services for Survey for 24 years. She became a key opinion leader in contraception and lectured both nationally and internationally. She gained her menopause specialist qualification whilst working at Shell West. She now runs the menopause consultancy concentration on women's health. For the last 6 years, she has had an interest in mast cell activation syndrome and histamine intolerance sparked by diagnosis of her daughter in 2016. Since then, she has helped many patients with this condition to improve their health and quality of life. More lately, she has been treating long COVID patient. And just to connect a dot over here, long COVID patient, there is a suspicion that some of them have mast cell activation syndrome. So this is a very important talk that I think you would enjoy listening and learn a lot from. Dr. Manjul Methi will be with us tomorrow as well. Dr. Mehdi has been working as a consultant in infectious disease at Forth Valley Royal Hospital since October 2017. Since that time, he has been part of the small team setting up a brand new infectious diseases and OPAT service. He has previously worked as a junior doctor in several ID departments in the UK, including Aberdeen, Dumfries, Newcastle, Liverpool, Manchester, and in London, as well as an internist in service development. He also has an interest as well as so for his interest in the service development, plus he has interest in medical education and has previously worked for the University of Aberdeen for 2 years as a clinical teaching fellow. And last but not least, Professor Matthias Zwitter, MD and PhD, head of the Department of Medical Ethics and Law, Medical Faculty, University of Maribor, Slovenia. His 2 papers on ivermectin for COVID-19, as published in Slovenia Medical Journal, ISIS, and in leading newspaper, Dello, stirred a vivid debate among medical and lay community, hopefully leading to a change in the current medical practice. He was co-editor of the 2 books on communication, Communication with the Cancer Patient, Information and Truth, the New York Academy of Sciences, 1997, and New Challenges in Communication with Cancer Patients, Springer, 2013. He also wrote and published 3 books talking about medical ethics in Slovenian language, Kankerjeva Zalozeba, 2018. I hope I'm pronouncing these words correctly. Medical Ethics in Clinical Practice, Springer, 2019, and Talking on Euthanasia in Slovenian language, Slovenia Metica, 2019. With this, I also wanted to make sure, and I deliberately kept this one, Dr. Lawrie's introduction at the end. So Dr. Lawrie and her team, the BIRD group, her colleagues, they have made this conference possible. So thank you, Dr. Lawrie, very much. Here is how Dr. Lawrie's own bio is. So Dr. Tess Lawrie, BIRD group convener. Tess MBBCH, PhD, is the director of E-BMC Limited and E-BMC Squared, a community interest research group. Tess is committed to improving the quality of healthcare through rigorous research. So that is her specialty, and that is what is the key backbone for all the work she's doing for COVID at this time. Her range of research expertise based on research experience in both developing and developed countries uniquely positions her to evaluate and design research for a variety of healthcare settings. And this is why you can also trust the data that is coming out of this conference, that has gone through her and her colleagues' review, and the data can be trusted, and she has analyzed it and she has presented it in a way that is authentic for us. Tess is a frequent member of technical teams responsible for developing international guidelines. Her peer-reviewed publications have received in excess of 3,000 citations, and her ResearchGate score is among the top 5% of ResearchGate members. So this is the star-studded discussion forum that we have today. Once again, I'm going to start with my part of the discussion. Tess and colleagues, thank you very much for doing this. After listening to the participants today, the structure will be a participant will present, we will curate the questions that you have during their presentation, and then we would ask those questions from them. We would try our best to ask as many questions as possible, but the time is limited, so I cannot promise that everybody's question will be asked. We might do some follow-ups afterwards. And at the end of the day, we'll do a summary of the day, and then we would plan for tomorrow. So with this, thank you very much. And I'm going to share my screen and start with the ivermectin's mechanism of actions. So first of all, so the agenda for me today, I want to discuss some of the possible mechanism of actions of ivermectin in context of COVID. So some of these are in silico studies, some of these are in vitro studies, and the most important thing is that as doctors have been practicing and using ivermectin, majority of these potential mechanisms, you would see that these are playing, and clinically we can observe the outcomes. So today we'll talk about that ivermectin docks with the SARS-CoV-2 spike proteins. Ivermectin docks with the ACE2 receptor as well. Ivermectin, so all of these are the potential mechanisms. Ivermectin disrupts the function of the RNA-dependent RNA polymerase, or viral RDRP. Ivermectin disrupts the function of 3-chymotrypsin-like protease, or 3CL-Pro, or M-Pro as we call it, and we'll discuss that today as well. Ivermectin disrupts the important alpha and beta usage by the SARS-CoV-2 cargo. We will discuss that today as well. And finally, ivermectin modulates inflammatory system by a nuclear factor kappa chain for the B cells. So let's start our discussion. So here, if you see, I hope that you can see this screen. Let me just very quickly make sure. Cool. So first, mechanism. So imagine that this is our cell here. And in this cell, we have SARS-CoV-2 that has arrived. So we know that the SARS-CoV-2 arrives in the cell either by phagocytosis or pinocytosis, or by binding with the ACE2 and fusing with the cell membrane. So both of those processes are possible. Eventual outcome is that the virus has been released, or broken pieces of it have been released in the cytoplasm. And then as the virus is making its cargo, and virus is having its proteins being transformed and created through our ribosomes, what happens is one part of that is so let's say this is a ribosome and it has used the viral messenger RNA and produced viral proteins. These viral proteins, some of them, which we call viral cargo, and the reference for this one is the Kelly's discussion here. So the FDA approved drug ivermectin inhibits the replications of SARS-CoV-2 in vitro. Here is the mechanism that I'm discussing. So what happens is this cargo of the virus, it connects with our proteins called importin alpha and beta, and then it goes through these importin alpha and beta with the virus cargo. They go through the nuclear pore complex, they enter the nucleus, and then inside the nucleus, the message from the virus asks the nucleus not, or our DNA, not to express the genes that would enhance the cell survival and that would allow the cell to release interferons. We know that the cells, when they are sick with viruses or bacteria or cancers, they tend to release interferons to alert the neighboring cells to shore up their own defenses. And this is what SARS-CoV-2 tries to suppress. Ivermectin disrupts this process by binding. So if we see here in the next diagram, here if you see this little block of black, let's call that ivermectin. Ivermectin can bind with the importin alpha and beta and disrupts their process, and hence the virus cannot send its cargo to our nucleus, and the nuclear defenses that are suppressed are not suppressed. The result is that the nucleus can continue to have the gene expression to make interferons that would allow the nearby cells to receive the interferon messages and start shoring up their own defenses as well. And that is one potential mechanism by which ivermectin keeps our cells stronger and prevents the cells to be unnecessarily damaged by SARS-CoV-2. Second mechanism. So this is an in silico study. All of those studies, the references are there. So here is the second mechanism. Ivermectin docks to the SARS-CoV-2 spike receptor binding domain attached to ACE2, and this plus this one, identification of 3-chymotrypsin. So here, if you see, This is a SARS-CoV-2 virus. This is our cell. On the cell, this is the ACE2 enzyme or ACE2 receptor that is working with ivermectin. It acts as a receptor for ivermectin. And if you see here, this is the spike protein of the ivermectin. Spike protein, as we know, has S1 domain, S2 domain, and with the S1 domain, we have receptor binding domain. So part of the spike protein S1 is the receptor binding domain. That receptor binding domain is responsible to bind with ACE2. The S2 domain has fusion protein with it, which binds with the cell membrane after priming with TMPRSS2. So the end result is that this binding leads to the fusion of ivermectin with our cell and entry of the RNA into the cytoplasm. If you see here, this red block is ivermectin. Ivermectin in silico studies have shown to be connecting to the RBD of the spike protein plus the ACE2 enzyme. So it almost becomes a hindrance for the virus to be able to successfully bind and enter the cell. So that is a very important mechanism, potential mechanism that disrupts the ivermectin's SARS-CoV-2's function. Continuing on, mechanism number 3. So 3 chymotrypsin-like proteases. So what happens is, if you focus here for a second, when the virus is in the cytoplasm, it releases its messenger RNA or its positive sense RNA. That RNA is picked up by the ribosome. Ribosome would then translate that into a big protein called polyprotein. All of you are doctors here, healthcare professionals here, you know that this is a normal behavior of the viruses and their reproduction. So once that polyprotein is made, that is like all of the enzymes of the viruses are stuck in one cutout paper. Then what happens is, through autoproteolytic mechanism, meaning some enzymes break off of this loose polyprotein by themselves, that is called the autoproteolysis, and then they further help break down this polyprotein into individual enzymes, which will then help for the virus to do its function and make its copies. So one of the protein that breaks off in the beginning is the 3 chymotrypsin-like protease, or we call it MPRO, or we call it 3CL-PRO as well. This protein is a protease, as the name says, which will then work on this polyprotein and liberate the remaining enzymes for the virus, which will then start replicating the virus. So you can actually imagine that if we suppress this enzyme, then the remaining virus work or virus production will become stalled. So ivermectin binds to this enzymes as well and disrupts it. So this is another potential mechanism by which ivermectin would disrupt the possible replication of the virus in our cells. Next mechanism is the RNA-dependent RNA polymerase disruption. So if I go here, this would be the here. So if you see this study, it is a preprint, ivermectin as a promising RNA-dependent RNA polymerase inhibitor. So what happens is, again, this is an in silico study. If you continue to follow this mechanism, once these polyproteins have come in and once they have started opening up into smaller enzymes, those smaller enzymes, one of them is the RDRP. This enzyme will help further make the genetic copies of the viral RNA. So imagine that we have the virus and we are going to build new viruses, and then in each virus we have to put a brain or the messenger RNA of the virus. So RDRP would start helping us turning the positive sense messenger RNA into a negative sense, and then from negative back to positive. Plus sub-RNA or partial RNAs are also created, which would do various functions inside the cell by creating enzymes. This RDRP enzyme is a backbone for the viral replication, and ivermectin is potentially, in silico studies show that it binds with the RDRP as well and possibly disrupt it too. So that is another very interesting and beautiful mechanism. Continuing, final important mechanism is the ivermectin disrupting nuclear factor kappa light chain B for B cell factor. This factor is actually, so from the B cell, don't be alarmed that this only happens in the B cell. This actually NFK beta pathway, pathway is present in all cells. So here what happens is, imagine this part, these two little proteins here, if I can make it a little bigger, these two proteins are the NFKB. They are usually present in the cytoplasm of a cell and are kept inactivated by IKBA. Now, when some signal arrives at the cell, or some stress occurs, or some reactive oxygen species are produced, or cell is under attack by a virus, then what happens is this protein complex is activated, and the activation causes the IK beta to be separated and the NFK beta to be separated. This NFKB then goes into the nucleus, and from there various gene expressions occur and various cell responses occur. For us, what is important is inflammatory responses. Ivermectin can actually dock with the NFKB as well and disrupt its function. So this study is actually done for the LPS from the bacteria. However, it shows that in the presence of ivermectin, inflammatory system is modulated as well. So these are 4 or 5 mechanisms that are used by the ivermectin to disrupt specifically SARS-CoV-2 like viruses, modulate the inflammatory system, and potentially all viruses that have RDRP or 3-chymotrypsin like enzymes. So with this, thank you very much for listening to the discussion. Let us now move to our first. If you have any questions, we'll answer them, and then we'll move to our next panelist, Dr. Lawrie.
Thanks very much, Dr. Bean. Well, from what you've described, it's clear that ivermectin is a potent antiviral, not just an antiparasitic agent, with all those different mechanisms of action. My question is, and this was also sent to us via email, is what would be the mechanism of action in long COVID, if there is one?
Very good. I'm going to share my screen again, and this is a very, very important question, has been brought up many times. So just in a quick summary of the long COVID could be for many reasons. And of course, there is a lot of research happening right now. As the more data evolves, we will keep our folks here up to date as well. One possibility of long COVID is the SARS-CoV-2 itself hiding somewhere in our tissues. For example, there is a study that shows that SARS-CoV-2 can continue to sit in the gut epithelial cells for a longer period of time. So it is possible that the virus finds some place to hide. There is another discussion, another research done by Dr. Bruce Patterson and his group, who are researching on long COVID, and they feel that monocytes have remnants of the SARS-CoV-2 present in them, and they are replicating with the monocytes. So there is one possibility that SARS-CoV-2 is present. Another possibility is that something that is called hit and run by viruses. And hit and run is where a viral infection occurs and our immune system gets dysregulated. There may be many other possibilities, for example, mast cell activation syndrome or macrophage activation syndrome, and so on. So there are more mechanisms there to be seen. Now, if a person has long COVID, and the reason is that there is some possibility of the SARS-CoV-2 hiding somewhere, one, or there is some possibility that some inflammatory dysregulation has occurred, which of course, from the symptoms, you can tell that there is some inflammatory dysregulation that is going on. For both of them, ivermectin can actually help. As we just saw from its mechanism, that it helps disrupt the virus's own replication, plus it helps modulate the inflammatory system as well. So in the long COVID, the way to work with ivermectin is to administer the ivermectin and see if that is making sense. And if that is improving the patient, that means there may have been some remnants of SARS-CoV-2 that are being eliminated now, or it is also possible that there is some inflammatory modulation. The way to now see that if that modulation is working or not, if you stop ivermectin and if things come back, that means either give ivermectin more, or there may be other mechanisms that are going on as well. So I hope that answers that question, Dr. Lawrie.
Thank you very much. I think that is the only question. So, and we're in time. So, we're just right on time for the next presentation.
Excellent. So thank you very much for this. Our next speaker is Juan Chamie. So Dr. Lawrie, have you had your discussion?
No. It's me next. I'm next.
Okay, so yes.
Yeah.
So our next speaker is, apologies. So our next speaker is Dr. Tess Lawrie. As I have introduced her before as well, she is the convener for the BIRD group, and we have seen her bio before. You must be seeing that on the slide as well. Dr. Lawrie, please, over to you.
Thank you. I pre-recorded my presentation just in case you're wondering, so that I could stick to time.
So Dr. Lawrie, we cannot hear you yet.
Sorry.
So Dr. Lawrie, there is a comment from a team member.
Good afternoon from Bath, UK. I'm Dr. Tess Lawrie, and I'm speaking about the latest systematic review evidence on ivermectin. On the 4th of April, we heard that the UK government aims to create a COVID super pill that combats effects of the virus and can be taken as soon as someone tests positive. This week we heard that the government is putting together a task force to look into antivirals that people can take at home. I would like to show them and you that we already have a cheap, safe and effective antiviral to treat COVID at all stages. This antiviral is ivermectin. We have recently completed a systematic review of ivermectin to prevent and treat COVID. The review team comprised 3 experienced systematic reviewers, a health economist, 2 specialist clinicians and a consumer representative. We submitted the protocol to Cochrane on the 14th of January and it is now published on the E-BMC website. For the systematic review, we followed strict Cochrane methodology, including randomized controlled trials only. We assessed risk of bias for each individual study and we used the grade approach to assess the certainty of the evidence. This paper is currently under peer review. Why was it important to do systematic review of the evidence on ivermectin? Systematic reviews with meta-analysis of randomized trials are considered the highest level of evidence because for a variety of reasons, single trials often produce different results. Therefore, most health authorities use systematic reviews to support clinical practice guidelines. With ivermectin, a large body of evidence has accumulated, including numerous randomized trials, warranting urgent review of the evidence. How is systematic review evidence assessed? Well, each individual trial is assessed for risk of bias for the same criteria, based on randomization, allocation concealment, blinding of participants, attrition, selective reporting, and other biases. Once the meta-analyses are done, the certainty of each finding is assessed using the grade approach. How this works is that randomized trial evidence starts at high certainty, and then it can be downgraded by -1 or -2 levels for design limitations, inconsistency, imprecision, indirectness, or publication bias. Thus, a downgrade by 1 level would lead to moderate certainty, 2 levels would lead to low certainty, and 3 levels would lead to very low certainty. So how do we interpret the evidence? Well, if we have very low certainty, we say we are very uncertain about this estimate. If we have low certainty, we say further research is likely to change the estimate of effect. If we have moderate certainty, we say further research may change the estimate of effect. And if we have high certainty, we say further research is unlikely to change the estimate of effect. Using this rigorous system of evaluation, in my experience, clinical practice recommendations are seldom based on high certainty evidence. For example, the WHO recommendation on steroids for critically ill COVID patients is based on moderate certainty evidence from 7 studies for the effect on death, and the conditional recommendation on remdesivir that has facilitated its widespread use is based on low certainty evidence. So what were our systematic review questions for the ivermectin for COVID review? Number 1, for people with COVID, does ivermectin compared with no ivermectin improve health outcomes? And number 2, for people at higher risk of COVID, does ivermectin compared with no ivermectin improve health outcomes? What did we find? We included 24 randomized trials. 3 of these were quasi-randomized trials. There were 21 treatment trials involving 2,668 participants, and there were 3 prevention trials involving 738 participants. Trial size ranged from 24 to 473 people. Most trials were registered, self-funded, and clinician-driven. With the exception of 1 trial, there were no obvious conflicts of interest. Treatment trials were conducted in 15 different countries. Prevention trials were conducted in Argentina and Egypt. Our primary outcome for the treatment trials of ivermectin versus no ivermectin was death from any cause. 15 randomized trials are included in this meta-analysis with almost 2,500 participants. The resulting risk ratio of 0.38 corresponds to a 62% reduction in deaths with ivermectin compared with controls, with a p-value of 0.004. We subgrouped trials according to whether participants had mild to moderate or severe disease, and the test for subgroup differences suggests that ivermectin's effect was similar for all stages. To investigate heterogeneity of the findings, we did sensitivity analysis by removing 1 study that caused inconsistency in the analysis, and the results were similar to the original findings. We also did pre-specified sensitivity analyses excluding 4 studies at higher risk of bias and trials with active control treatments, and in each sensitivity analysis the findings were consistent, showing a clear benefit in favor of ivermectin. We graded the certainty of the evidence of this clear reduction in deaths as moderate certainty, downgrading by 1 level for design limitations. With regard to secondary outcomes, our meta-analysis of 5 trials showed that 25% more people with mild to moderate COVID improved with ivermectin, and 65% fewer deteriorated. The evidence also suggested a shorter time to negative PCR. We graded these outcomes as low certainty, meaning that the estimate of effect is likely to change. This is the forest plot for improvement. It includes data from 1,354 participants in 5 trials. Subgroup data were not pooled due to inconsistency between the mild to moderate and severe disease subgroups. However, for both groups, the findings clearly favored ivermectin. Similarly, the findings for deterioration clearly favored ivermectin. This analysis includes data from 1,587 participants in 7 trials, and subgroup findings were consistent. This is a summary data table of secondary outcomes. You can see that the mean time to a negative PCR test averaged around 3 days fewer in the ivermectin arm across 4 trials. For certain outcomes, including admission to ICU and the need for mechanical ventilation, the evidence was very sparse and there was no clear difference between ivermectin and the control groups. For the outcome serious adverse events, 11 trials involving 1,533 participants contributed data. Few participants experienced serious adverse events, and there was no clear difference between the ivermectin and control arms. We downgraded this evidence by 2 levels to low certainty due to design limitations and imprecision. The primary outcome for ivermectin versus no ivermectin for prevention of COVID was COVID-19 infection. Data from randomized trials only were limited to 3 trials involving 738 health workers and family contacts of people with COVID. These showed a reduction in COVID infection by an average of 86%. In these pooled trials, overall, 5% of health workers and family contacts in the ivermectin group got COVID, compared with 30% in the control group. The evidence was downgraded 2 levels to low certainty for design limitations, meaning that ivermectin may reduce COVID infections by around 86%, and further research is likely to change this estimate of effect. Based on our data, however, the number of health workers one needs to treat to prevent 1 COVID infection is 4. Out of 538 people taking part in 2 trials of ivermectin for prevention, none had serious adverse events. So to summarize the findings of the systematic review, ivermectin probably reduces the risk of death from COVID by an average of 62%. More people may improve and less deteriorate if they're given ivermectin. Ivermectin given for prevention may reduce COVID infection by 86%, and there may be little or no difference in serious adverse events. When making clinical practice recommendations, there are several criteria that are taken into account. The effects, as evaluated in rigorous systematic reviews of the clinical data, how much people value these outcomes, for example, the effect of ivermectin on death, how costly are the interventions, are they available to all, how acceptable are they, and how feasible. With regard to values, it is obvious that everyone values interventions that reduce death for COVID. So I will go straight to some of the resource considerations. Is ivermectin cost effective? We know that the direct costs associated with COVID infection are high. In developed countries, hospitalization rates have been estimated at 5 to 10% of COVID infections, and 25% of those hospitalized require intensive care, with the cost of 1 day in ICU estimated at around £4,520 in the UK. The average hospital admission in the US costs around $7,207 for moderate COVID and over $33,000 for severe COVID. Therefore, an early antiviral treatment that can be used as soon as someone tests positive and prevents deterioration, hospital admission, and deaths has the potential for large cost savings. Ivermectin is inexpensive. It's a World Health Organization essential medicine with a direct cost of as little as 3 cents per 12 milligram tablet and possibly around 50 pence in the UK. Merck no longer has the patent on ivermectin, and there are many manufacturers worldwide. It also has low storage costs as no refrigeration is required, and virtually no administration costs as it can be self-administered in the early stages. These factors further favor the use of ivermectin. What is the impact of using ivermectin on health equity? There are many reasons why ivermectin will improve health equity, and here are a few to consider. Some people are at higher risk of COVID infection and adverse outcomes. For example, in the UK and the USA, Black, Asian, and minority ethnic groups experience worse health outcomes with COVID than other ethnic groups. Therefore, a cheap and effective pill that can be taken early in the infection would improve equity. Ivermectin is known as safe for the vulnerable, including the elderly and the immunocompromised who are at higher risk of adverse events from COVID. And frontline workers are at higher risk and would benefit from a safe pill that can be taken pre or post exposure to COVID. The slow rollout of vaccines in low and middle income countries means that people in these countries need an alternative whilst awaiting safe and effective vaccines. In addition, some countries are awaiting further vaccine safety data, so urgently need alternative measures for COVID. Systematic review evidence shows that a significant proportion of people suffer from needle phobia, so ivermectin would offer such people who don't wish to be vaccinated an alternative. And finally, healthcare waiting lists are growing, with approximately 1 in 5 people waiting for non-COVID medical care in the UK. Rolling out ivermectin would enable these people to receive the non-COVID care that they need. Would ivermectin be acceptable and feasible? Based on the evidence that ivermectin probably substantially reduces deaths from COVID with few serious adverse events, logic suggests that ivermectin would be acceptable to the public and health professionals. Emergency use authorization has been acceptable for vaccines and other newly developed drugs based on lower certainty evidence, so it should be acceptable for ivermectin, which is a well-established drug with a long safety record. Ivermectin has extensive safety data and is used in the elderly and recommended in the immunocompromised, and if it's okay for vulnerable groups, it's likely to be acceptable to all. Further, on ivermectin's safety profile, more than 3.5 billion doses of ivermectin have been given over the past 4 decades, and yet only 5,236 adverse events and 19 deaths have been registered on the vigiaccess.org pharmacovigilance database since 1992. Novel treatments, such as remdesivir, for example, had 5,801 adverse events and 503 deaths registered in the past year, and the COVID vaccines had over 500,000 adverse events and 3,440 deaths registered in just the past few months. As ivermectin is considered an essential medicine by the World Health Organization, ivermectin is widely available in most countries, some as an over-the-counter medicine. In other countries like Switzerland, the USA, and the UK, off-label use of ivermectin for scabies is supported. In addition, health authorities recommend that ivermectin is used for immunocompromised people with COVID to prevent parasitic infections. Thus, since health authorities already justify off-label usage of ivermectin for a less dangerous disease than COVID based on less evidence and recommend its use among the most vulnerable with COVID, it makes sense that these authorities should also support off-label use of ivermectin for COVID treatment. Based on much of the above, additional considerations and more, the British Ivermectin Recommendation Development Group recommends ivermectin for the prevention and treatment of COVID-19 to reduce morbidity and mortality associated with COVID-19 infection and to prevent COVID-19 infection among those at higher risk. The BIRD recommendation may seem confusing to some in light of the recent WHO recommendation against ivermectin for COVID treatment, except in the context of a clinical trial. The WHO based their decision on the findings of a network meta-analysis that utilized only a fraction of the available trials of ivermectin for COVID treatment. They state that the evidence was rated as very low certainty because of the very serious imprecision for most outcomes. They say the aggregate data had wide confidence intervals and/or few events. So let's take a look at their summary data. For mortality, the WHO findings of an 81% reduction in deaths was based on data from 1,419 participants in 7 trials. Despite the precision of this effect estimate, with a confidence interval of 64 to 91%, this evidence was downgraded twice for imprecision, leading to a grade assessment of very low certainty. This is the WHO's published forest plot for the death outcome. Only 5 trials in this one, not 7, and a different effect estimate to that published in the summary table, yet still showing a clear effect in favor of ivermectin. For serious adverse events, the WHO team downgraded the pooled data from 3 trials for serious imprecision, as events were rare in these trials, and the effect shows no difference in serious adverse events between the ivermectin and control groups. However, they erroneously conclude from these data that ivermectin may increase the risk of serious adverse events, leading to drug discontinuation. There are no reasonable or statistical grounds, in my opinion, for this interpretation of these data. The double standards evident in the WHO's published concerns that there may be treatment-related adverse events with this well-established and trusted medicine is frankly bizarre, given the risks inherent in the drugs currently granted emergency use authorization. Thank you for considering the evidence I've presented with an open mind. I look forward to your questions.
So thank you very much for Dr. Lawrie's great talk. Thank you so much. Even while I have been talking about ivermectin for a long time, these are the kind of issues that we keep hearing about. And so thank you for clarifying that. And thank you for clarifying the data behind it. A few questions for you, if you're ready.
Yes.
Perfect. So one question that is very, very common nowadays, and that is that given the government and WHO are not listening to the evidence that ivermectin is a game changer, what can be done to protect doctors and their licenses to practice who follow the evidence and prescribe ivermectin for their patients?
Thanks for the question. Well, I think, doctors who are prescribing ivermectin or wanting to prescribe it need to obviously exercise their right under the oath that they've taken, their Hippocratic Oath, as well as the Helsinki Declaration, and that they are entitled to use treatments that they believe will help their patients. And that is our fundamental right. And in fact, we're obliged to do so. But in terms of protection, I think the protection is in numbers, and I think we need to stand together as doctors and support each other to be able to stand up to the authorities and the politicians who are saying we cannot use medicines that are useful, that we know to be useful and safe. And a way that you can do this is by connecting with the Bird group. You can sign up to our newsletter or contact me via email, and we can connect you with others in a similar position as you. The other thing is, I think as a group and as a global group of doctors, we need to be demanding more transparency from our authorities, and we need clarification from WHO. We need, for example, all our bird proceedings and all other proceedings have been open and transparent to the public, and our analyses too are available. And the WHO should be providing a video of their proceedings, of how they reached this recommendation, so that there's a transparency and accountability, and we can see why they're only looking at a fraction of the trials when there's a huge body of evidence, not just systematic review evidence. If you think about the evidence we have on ivermectin, I've only presented the randomized controlled trial evidence, but that's the top of the pyramid. There's the randomized controlled trials below the meta-analysis, and below that you have the observational studies, and below that you have expert opinion, real world data. So there needs to be a clear explanation to doctors and the public as to why they're insisting on looking at just a fraction of the data that's available on ivermectin.
Got it. Thank you very much for this one. Because this is a concern, some of my doctor friends have reached out and said, hey, what are the legal implications for us now who are using it? Another question that is very common, and that is about the doses. So what doses of ivermectin were used in these trials that you have discussed and reviewed?
Well, there was a range of doses. Some were single dose, and some, but most were multiple dose. And we did do a separate pre-specified analysis looking at ivermectin according to the doses. So if you can bear with me a moment, I can share a screen with you.
Absolutely.
Let me just. Can you see that?
Yes.
Okay, so this is the forest plot of death our primary outcome for the treatment trials. And you can see all the trials listed down the left-hand side, ivermectin data in this column, control data in this column. And we've subgrouped here single dose, multiple doses. And this was one study that used single and multiple doses depending on various criteria. So we put it in its own group. But you can see most of the studies that used single dose were in early disease, except for the Gonzalez study, which was in very sick patients. And you can see a single dose didn't really have much effect. There was no clear difference, although the numbers are very small. There isn't a very, it's not very high certainty evidence, but it does suggest, by looking at the test for subgroup differences, although it's not significant, it does suggest that multiple dose therapy is needed, does better than the single dose therapy, and accounted for most of the effect that we were seeing in the deaths analysis. And the doses used in these studies were about 0.2 milligrams per kilo to 0.4 milligrams per kilo, and then it was from sort of 2 to 5 days, and it varied across the studies.
Got it. So did I catch it correctly? So was it 0.2 milligram per kilogram to 0.4 milligram per kilogram?
Yes. So some of the studies, and that works out at about a 12 milligram tablet for a 60 kilogram person, or 24 milligrams. Got
it. Thank you very much. This is a very, very common question. One request to the audience, if you have any questions, please put them in the Q&A tab or the question and answer tab. That is where it is easier for us to curate those questions and respond to them compared to finding them from the question stream, from the chat stream. So with this, we have a couple of more questions, Dr. Lawrie, that I saw in the questions. One is that, can ivermectin become resistant to mutants?
I'm probably not the best person to answer that. I think you are. Would you mind giving us your opinion on that?
Absolutely. So I'm going to quickly share my screen and discuss that how ivermectin's mechanism and mutants work. So if I go back here to the same mechanism once more and just discuss these one by one. So let's say that we are dealing with a mutant, any mutant, let's say 135 or 117 or the latest mutant 617. When a mutant arrives in our system, it does the same thing, and that is it has to enter the cell, and then it has to, for example, one part of its function is to use its cargo. And when it is using its cargo, ivermectin is still there. So it doesn't matter what mutant it is, ivermectin would still block the importin alpha and beta, potentially block them. Similarly, so far all mutants have still been able to bind with the ACE2. So even if there is some changes in the spike protein, but the mutant still needs to bind with the ACE2, as long as that is the case, ivermectin would keep hindering their binding capability with ACE2. Then when the mutant arrives in the cell and they are making their polyproteins and they make their mpro protein, which is common to all mutants, they have not made any change in this area, ivermectin would continue to support and disrupt them. By support, meaning support us and disrupt the virus. Similarly, if you see here RDRP, there are some reports of mutations in the RDRP, but these are minor mutations. The functional RDRP that is present in the mutants is still a good target, or I should continue to say potentially good target for ivermectin. And finally, the nuclear factor KB pathway, that mutants have nothing to do with that, and ivermectin would continue to do that. So that is how ivermectin would stay strong against the mutants as well. Dr. Lawrie, there is one more question, and that is about the ivermectin and
actually, Dr. Bean, could I just wanted to mention, I have received correspondence and I have been in communication with doctors in Brazil who have been dealing with the mutant strains. And they say that ivermectin is continuing to work, but they are using higher doses. So they're using the 0.4 milligram per kilo rather than 0.2 and for longer, and in combination with other therapies. So that's Brazil. And also from India, I heard from a colleague that they are using a loading dose of 24 milligrams. So the 0.4 milligram and then continuing with their protocol. So I think with perhaps some of the strains, the higher dose, the 0.4 milligram per kilo, is what's working best.
Sorry. And that is a very, very important point. And the reason is very simple. Most of the mutants are able to, they're more contagious, so they can get into the cell faster, rapidly. And that means if there are a bunch of viruses sitting outside the cells, they're going to get into the cell and quickly start replicating. So we need a larger quantity of ivermectin to get into their way and hinder them. So very important point, and thank you very much for bringing it up. One more question. Somebody is asking this question that can we use a generic form of ivermectin? Is there a brand that has to be followed, or ivermectin is manufactured in so many countries?
Well, that's exactly the beauty of ivermectin, is the beauty and the reason why we're having difficulty getting it approved, I think, is because it's generic. Any manufacturer can apply to make it, and it can be available cheaply in the country, in whichever country it's made. It would be, if it's in India, it's going to be cheaper than if it's in the United States, for example. But in relation to other new drugs that are branded, it's very cheap in whichever country you get it. So so there are many different brands, and you can source these.
Very good. I have a couple of more questions if you have time. I think these are important questions if we can get to them.
Yes, I think we do have time.
So one question here is from Chrislyn. Ivermectin is not widely supported for prevention and cure here in our country. How should we take ivermectin as a prevention and cure? May we request for some protocols that we can look at? So one, they are requesting that what should we do for prophylaxis, and is there a protocol that we can refer?
Well, there are various protocols, and Dr. Corey is presenting protocols tomorrow. That's the subject of his talk. So I don't want to step on his toes. And the FLCCC, his organization, has their protocol that they're using, but there are many different protocols around the world which he will be talking about.
Perfect. Thank you very much. One more question, and that is that I do not know that is addressed to whom. So Monica is saying, in one of your interviews, you mentioned that the protection that ivermectin provides is the same as the vaccines. Did I remember that correctly?
I don't believe that I've said that in a presentation. So yeah, I think it might be a very useful strategy, because vaccines are being very slow to roll out, and there are various issues with their rollout in different countries. So ivermectin certainly is very efficacious. I haven't done a comparison with the vaccines, but it is widely used, and it is protecting healthcare workers around the world. And our analyses based on the 3 trials the randomized trials, was that showed an 86% reduction. So it's very efficacious, and this is supported by a huge body of observational studies and data.
Excellent. So, thank you very much. So I think that can I summarize your message as it is a good bridge to reach the vaccination milestone, and that it in itself is a drug that should be looked at instead of comparing with the vaccines or saying it is better or less better.
Yes, I don't think we need to make a comparison at all. I think we should be using all the tools at our disposal. Yeah.
Makes sense. So I think these are the questions. There are a number of more questions here. I think we would spend a lot of time doing those questions. as more participants come in, we would continue to answer those questions as well. Dr. Lawrie, once again, thank you very much for your help and your questions and for this conference as well. You and your colleagues, great job. Thank you. For the audience, let us take a quick break and we would come back with our next speaker in a few minutes. Hey, Dr. Lawrie. So if the participants are here, what we are seeing is that there is a very large number of questions. So I thought, and Dr. Lawrie was thinking, and the colleagues are thinking that instead of taking this break for a longer time, why not we utilize this time as well to answer some of those questions? So Dr. Lawrie, are you ready to answer some questions?
Yes, yeah, let's go for it.
Excellent. So thank you very much for giving this time as well. So I have some questions that we've curated through the questions in the list. And once again, a reminder for the audience, please put your questions in the Q&A tab so that we can go and curate them from there. So one question here, there seems to be many clinical trials going on, but when could we expect the evidence to change a government view on using ivermectin?
Yeah, that's quite a difficult one. I think it's very difficult to understand why the authorities are not recommending ivermectin, and I have personal views on this. I think it's because the the investment in novel treatments is so great that there isn't a will to look at generic treatments that are very cheap, and so there are a number of ongoing trials. On the one hand, I'd like to just say I think it's totally inappropriate for us at this stage to be looking at randomized trials on ivermectin because it works, and placebo-controlled trials in any event, I still believe are not ethical, especially we're talking about something that has a dramatic effect on cutting deaths. So, if you actually, have a patient in hospital and you say, we've got this very safe old medicine that's been around for 40 years, and it looks like it reduces your chance of dying by about 60%. Would you like to take this, or would you like to take a placebo? I just don't think there's any way you can actually consent anyone to a randomized trial if you are actually providing them with the evidence. But there are a number of ongoing trials, and these, will be reported in the next few months. But there are a number of issues because studies on randomized controlled trials on ivermectin are having great difficulty getting published. So there's a number of them all sitting on preprint servers. There's been a certain amount of almost censorship around publishing trials on ivermectin for whatever reason, which I'm sure will become, come to light at some point. And so, and since the authorities are insisting on these published randomized controlled trials, I think we have an issue. So it's very difficult to know when the authorities will approve ivermectin. I suspect they're waiting for novel treatments to be approved, these new antivirals that the governments keep talking about.
And that is, unfortunately, that is the sad situation at this time. In the similar vein, you touched about it a little bit as well. In the similar direction, are you aware of any large-scale ivermectin trials that may be about to be finished or are going to finish soon?
There is, yes. So there is a trial called the Together trial, which is, it's sort of put forward by the authorities as being a definitive kind of trial, but it's industry funded for all intents and purposes. And I'm not expecting that trial is going to show in favor of ivermectin. For trials on ivermectin, we need to be listening to doctors. We need to be listening to the doctors on the ground who are conducting these trials in order to inform the rest of the world and their colleagues. And I think we need to scrutinize the conflicts of interest very, very closely, particularly funding and analysis, who holds the data of the trials, to determine whether we can trust the output. We have to be very, very clear on funding of randomized trials around ivermectin, because it's really quite a threat to the pharmaceutical industry. If you think that the COVID pharmaceutical industry is worth hundreds of billions of dollars, and ivermectin costs so little. So, it can actually, it can really scupper, I guess, to a degree, the novel pharmaceutical drug industry around COVID.
Makes sense. And that is actually another sad thing. I actually believe that, as you said, that looking at the funding and looking at the trial itself, the design of the trial is also not only just looking at the people who are looking at the data, the design of the trial is also very important.
Yes.
A trial can be designed in a way that it would lead to failure. So that part is also concerning.
Yes, that certainly has happened. And in fact, if you look at the trials that have been published recently, they've had serious design issues, and it seems it's almost a reverse publication bias, because publication bias is when you have positive results that tend to get published, whereas with ivermectin, negative trials get published and the positive ones languish on the preprint servers, unable to find a home. It's really a peculiar situation.
Yeah. So 2 more questions, and we'll continue to go over the questions and look for them. One question that is actually very common in my discussions as well with the audience, that is about the ivermectin and pregnancy. Do you have any suggestion? Use it, don't use it less? What is the situation with ivermectin?
Our concerns around any drugs in pregnancy is particularly the first trimester, early on when the fetus is developing. And so, but ivermectin, like most treatments, are not tested in pregnancy. You don't do randomized controlled trials in pregnant women of drug treatments. So we have to use our common sense to a degree and weigh up the benefits and risks of taking a treatment if you're very sick with COVID. And as far as ivermectin in pregnancy, you need to remember that ivermectin has been used billions of times over the last 40 years, and it's used in community mass administration campaigns against parasites in Africa and Asia, where whole countries or states receive regular ivermectin treatments. So certainly pregnant women have been exposed to ivermectin. There is one randomized controlled trial of about 800 or 900 women, where women were randomized to ivermectin as an antiparasitic, and there were no fetal abnormalities or any adverse events from ivermectin among those women. So I think, as doctors, we have to weigh up the benefits and risks to our patients, but there's certainly no reason to think that you should not, if you feel that it would benefit your patient.
Got it. Thank you very much. One more question, and that is the overdose. So is it possible to overdose with ivermectin? I guess this may be because of the issues going on nowadays and people tending to take it. If the overdose occurs, what is the antidote? How do we protect that person?
I don't know of a specific antidote, but Merck did the original safety studies on ivermectin and showed that at 10 times the normal dose it was safe. There were no adverse events. And those were randomized controlled trials conducted in the late 90s, early 2000s. So no, those are published findings, because Merck had the original patent for ivermectin. I just lost my train of thought.
Yeah, so from the antidote point of view, if I can add a comment here as well, that in the textbooks, when they talk about ivermectin and any reactions, one type of reactions are the allergic reactions. And they talk about providing the supportive, withdrawing the drug and providing the supportive treatment or management for managing the allergy. Any other comment, Dr. Lawrie, you would like to add?
No, I don't think so.
Okay, so then one more question that I just saw. Is it safe to take ivermectin while breastfeeding?
Well, that is one of, it's also one of the contraindications. In the package insert, it says, should be avoided during pregnancy and breastfeeding. So again, I think it's a relative indication if you're talking about treating somebody who's very sick. So I think, it would be a question of the doctor deciding whether or not it was important, and it would be possible to, take the baby off the breast for a few days or a week or so if it was deemed to benefit the mother. If she really needed the treatment, well then, I would give it to her. And one would be able to make a plan with, with breastfeeding. So I would say it is supposed to be avoided during breastfeeding.
Got it. Thank you very much. There is a question addressed towards me. Annette Anderson says, Dr. Syed, I don't think you mentioned the CD147 mechanism of ivermectin, or I missed it. Sorry. So no worries. No need to be sorry. The CD147 binding mechanism and the original CD147 theory that the SARS-CoV-2 may be using that is still not validated correctly. So there is still more data that is needed. That one theory, I don't want to use the word debunk, but has been countered. So I deliberately didn't want to bring that up because I feel that we need some more data in that area. So I'm gonna, Dr. Lawrie, if you don't mind, I'm gonna sift through some of the questions and see if I can ask you some more questions.
I see there's a question there. Is it more effectively absorbed in the presence of fat? And I believe, yes, you should take it with a meal. It is best taken with a meal rather than on an empty stomach.
Absolutely. And the interesting thing is that when you are managing worms, for example, in the GIT, then don't take it with the fatty meal so that it can stay more in the GIT and work on the worms in the GIT. But if you are taking it for potentially for SARS-CoV-2, then take it with a fatty meal. Absolutely. There is a question from John, Dr. Lawrie. Under which circumstances is a dose higher than the customary 200 microgram per kilogram clearly indicated? When is higher dose indicated?
Well, I think we have to look at our colleagues who are using it for this advice, and there's a number of protocols. So many colleagues around the world are using a 0.4 milligram dose as a starting point. So it's 0.2 milligram per kilo or 0.4 milligram per kilo, and it seems as if our colleagues in India and Brazil are saying 0.4 milligram per kilo is a better dose against these new variants.
Makes sense. Dalia Gomez says, wouldn't BIRD approach Portugal? So if your organization can approach Portugal, a country that produces ivermectin, if they can make it official, it could be a game changer and could spread like a bushfire. Any comments on that?
I think we do need, there are already a number of European countries that are using ivermectin. There's Slovakia, there's the Czech Republic, Bulgaria is pretty much over the counter, Macedonia, and I think the opinion, certainly there's more information. Doctors are certainly wanting to use it. So I think we just need a few countries to take the steps to approve it, a few more, and I think it will just be obvious to everybody that it's what we need to be doing. And in terms of Portugal, we have, as a BIRD group, we have undertaken to send the documents to all the authorities, and you just have to, if you can send us the emails of your authorities so we know where to send them, we're happy to do that.
Got it. Thank you. There is a question from Patricia Temple. She says, can ivermectin be used for long COVID patients who have been vaccinated? Does it reduce ongoing COVID symptoms and morbidity?
Well, there are speakers who are going to speak about long COVID, so I think I'll leave that question up to them to answer. Tina and Dr. Tina Piers and Dr. Carvalho are speaking tomorrow about long COVID.
Got it. Thank you. So one question that is repeating a few times in by various people, but the question is similar. The question is, in India and Brazil, are they not using ivermectin, or are they using ivermectin? And if so, why do they still have a lot of cases?
Yeah, well, I'm hoping in the next session we have, the next speaker is Juan Chamie, and he's presenting the real world data. And I'm sure that he will have insights because he's been following this very closely, and he's, so he will have insights into what is happening. As I say, the only insight I can give you is that of my colleagues in Brazil saying that they've noticed that with the new variant, it is more virulent than the previous one, and they have been needing to use higher doses. But I think also one thing you need to remember in both of those countries, there are certain states that are using ivermectin and there are certain states that aren't. So it's not widely approved.
Got it. So one more question, and sorry that I have you on this rapid fire with the questions. I think it is useful. Jules Diasonoville, my apologies for the pronunciation. So their question is, will ivermectin treatment reduce risk of community transmission by stopping viral shedding?
Well, I think it should, because just logically, if it increases viral clearance, so instead of people shedding for 7 days, they're shedding for 3 days, then it should reduce transmission. So, it should be something we're using immediately and in conjunction with the other new modalities.
Got it. One more question from Scarlett Monahan, and they are a cool bean as well. They are part of my audience too. So welcome here. The question is, if ivermectin could be used with any easily available drugs for best efficacy, what would that be? Could it be used with quercetin or zinc to improve efficacy? And is there any data confirming this? I have heard of some trials in Canada regarding quercetin that sounds very positive.
Well, there are a lot of data coming out on different treatments, but I think what, certainly as doctors, what we need to do is just use our common sense as well, and to a degree stop taking instructions from the politicians in terms of what we shouldn't treat our patients with, because there are lots of things that haven't been subject to randomized trials that we use in our practice, and certainly things like vitamin D and zinc and other generic treatments that are widely used, that have been sidelined, should be used or tried, because treatments that we use anyway. I mean, antihistamines, for example, I know that doctors are using them for long COVID. Well, we're not doing randomized controlled trials to see whether or not you can use an antihistamine or not. It's a treat drug that we, and for example, we don't do a randomized controlled trial to see if we need paracetamol or not. We're told we can give paracetamol to COVID patients. So I think, we need to stop insisting on this, there's this top-down that you have to have randomized controlled trials on these generic drugs that we've been using for a variety of reasons, and we know that they have well-established safety profiles. We need to be using our initiative and thinking, what have we got in our toolkit that we can use at this time?
Got it. I know that we are coming to time as well, so just a couple of more questions while we reach that time. So Johnny Raya says, after getting a shot of the vaccine, when can you resume taking ivermectin? I will probably add a part to this from my side as well, that should we continue to take ivermectin after the vaccine?
I can't. I'm not really. I can't see a contraindication to taking ivermectin with the vaccine. So, you know, again, I think doctors need to, hopefully doctors, you know, this will become a discussion with doctors and we can thrash these things out and come to some consensus. But this is the sort of, what the audience needs to understand is we're sort of at the start of this discussion because we haven't had this discussion with colleagues en masse, and we're at the start. So we need to be really discussing and learning from our colleagues abroad, around the world, and reaching consensus on these things amongst ourselves as doctors.
Got it. One more question, dose related. Monica Petrova says, please, do obese people need other dosing of ivermectin, milligram per kilogram, than usual?
To my knowledge, it's the dosage per weight. So it would be the same 0.2 or 0.4 milligram per kilo, depending on what your doctor what protocol they were following.
Got it. So Monica, 0.2 milligram per kilogram to 0.4 milligram per kilogram with your doctor's advice. And if you think about it, whatever is the weight, as you multiply these drug numbers with the weight, you would come up with the dose that is necessary or needed.
I see there are a lot of questions about the spike of infections in India and so on. So hopefully Juan is up in a few minutes, and hopefully he can address those questions.
Perfect. So Dr. Lawrie, do you want to wait or do you want to answer a couple of more questions?
I'm happy. Let's keep going. There's so many questions.
So there is a question, Dr. Syed, repeating. So Billy Davis says, Dr. Syed, repeating my question, if one is taking ivermectin prophylactically, is it likely that she will develop natural immunity over time via continued exposure and prophylaxis use of ivermectin? In other words, will prophylactic use allow you to develop an adequate immune response while still preventing symptoms and disease? I hope the context is asked of too.
I'm not sure. I mean, these are the interesting studies that we can be doing. One thing that, you know, it does seem that if you take it, if you have an asymptomatic infection, so if you are a contact or whatever and you take it, it does make sense that you would have your own immunity. So in fact, you know, you probably have a better immunity because you've actually had the infection and you've fought it off than an immunity that is acquired. So I would think if you're asymptomatic and you have ivermectin, you're more likely to have a strong immunity to the virus.
Makes sense. So two more questions. One, I have actually been receiving this for you. You have appeared in my shows as a guest as well. So I have been receiving these questions for your work. How about ivermectin and UK? What is the progress there? Is it?
Progress here is very slow. The doctors, because ivermectin is not a licensed treatment for, it can be used off license for, off label for scabies, and also can be used in immunocompromised people with COVID to protect them from getting worms. The doctors are very unaware of ivermectin. And unlike in other countries where it's used so widely, you know, against all sorts of parasitic infections, and in many European countries, it's licensed for scabies. Yeah, it's been really tough going, trying to raise awareness here. And we've been totally ignored by the government, although, you know, since anyone who's been following this story will know that I first sent the report to the UK government on the 4th of January. So it's almost 4 months later, and we still haven't even had a serious acknowledgement or meeting with the health secretary or the authorities or the therapeutic task force. So it's extremely ironic, you know, that we've been sending them the evidence on ivermectin for the last few months, and they've set up a therapeutics task force to look into early treatment now, early antivirals, and they still have not mentioned ivermectin or even reached out to us to discuss it. So it seems like their focus is entirely on novel treatments. And this goes for other health authorities too. This absolute blanket rejection of the evidence, mountain of evidence on ivermectin, and the embracing of these new treatments that just do not have the safety profiles that ivermectin has.
Sad, but I understand. So one more question here from Christina Miro Mangual. She says, between 0.2 milligram per kilogram and 0.4 milligram per kilogram, is the use of ivermectin safe even with the low weight patients or even with the children?
Ivermectin is not indicated for children under the age under the 15 kilogram weight or under the age of 5, according to the usual sort of package insert. But but also children are not really that at risk of COVID, are they? They don't have bad outcomes, so it's unlikely to be a situation that you face. But then it would be up to the doctor managing managing the child to decide what would be in the child's best interest.
Got it. And if I can just, if I may add, that if somebody who's not a child, but they are an adult and still their weight is less, this is why the dose is actually talked about in terms of the kilograms. So it is per kilogram, regardless of they are, what is their weight. So obesity or lower weight, once again, calculation is per kilogram. One more question here. Johanna Kim T. Mane says, would really like to know if ivermectin is safe for patients with any stage of chronic renal disease or kidney disease who got COVID-19, including those already on dialysis.
I think that is a decision for the doctor, again, to weigh up the pros and cons for that particular patient.
Got it. There's a comment from Coy Cortez. We are attending from Philippines. It is 2307 hours here. Thank you very much for being there. Thank you for learning with us. Thank you very much, Dr. Lawrie, for answering all those questions. Let's get ready for our next speaker as well. Once again, star-studded show today, and such an important show. And I would have hoped that this kind of discussions are actually led by governments, and they are talking with the doctors and bringing these pieces of information to them. Once again, thank you very much to the BIRD group. Thank you, Dr. Lawrie, and your colleagues for doing this. So our next panelist is Juan Chamie. I have talked about him once before as well. He's a senior data analyst who has been tirelessly researching and spreading the word of ivermectin since early May 2020. So in his discussion and his follow-up, so we would love to know what is he found worldwide, how the ivermectin is being used, and what are the results of that. So let's start with, let's welcome Juan as well. So Juan, take it away.
Well, thank you very much for having me.
Very welcome. Thank you very much for being here. Thank you for your time and your insights.
Try to start it.
So
I think this is not working. Hello, everyone. Thanks to all of you for having me here. I'm excited to show you some real-world data about ivermectin use and the impact in COVID today. There is a lot of information to go through, so I'll jump in right in, and I'll be happy to answer any questions later on. This is what I'm going to present: an intro on how did this research journey start, Colombia, effectiveness of a solitary public announcement, Mexico, how a test and treat strategy is changing COVID-19 figures, and finally Slovakia and Czech Republic, results in 2 European countries open to try ivermectin. The first start, when Jose Natalio Redondo, a doctor in Dominican Republic, used this drug successfully and shared his first 500 successes. Right after, an outbreak in Iquitos, Peru, grabbed my attention, especially how a small group of people distributing ivermectin in mass curbed the disease. After that, the same pattern is happening again and again all over the world, and I'm trying to capture the most accurate values and share them. So let's start with the first case, how one solitary announcement increased ivermectin use in Colombia and changed the disease outcome. So early in July last year, the mayor of Cali, one of the biggest cities in Colombia, announced that he was planning to use ivermectin to treat COVID patients because some doctors' experiences showed that ivermectin was effective in treating COVID. Right after his announcement, most health officials in Colombia opposed what he was saying. The Minister of Health was against it. The Colombian FDA was against it. Even the president made a statement against it. And the mainstream media in the country also supported the position against the use of ivermectin in the country. So, and because it was all over the media, the interest in the drug increased a lot in the country. As you can see here, Google searches reaches a new high. And that doesn't mean that people were buying more ivermectin, but it's a good indication. And also it's important to know that in Colombia, ivermectin costs between $2 and $10 per unit, and you don't need a prescription to buy it in any pharmacy. But in addition to Google searches, sales also increased. Look at the sales in Colombia in July and August 2020, compared with the same month in the previous year, or compared with the month prior. But also notice that here in the north of the country, the sales were more predominant than the rest. So COVID cases and fatalities, what happened? During these 2 months, both cases and fatalities stopped growing and then plateaued. And after, there was a drop. And if you look at the mobility, there wasn't a reduction in mobility that could explain the decrease. It was pretty much the same. Is the drop enough evidence? No. So how can we better test the effectiveness of ivermectin? If ivermectin is effective and some people are using it, the overall case fatality rate ratio must decrease. So was there a
Juan, I think we are on the
reduction in case fatality ratio? Or was there a reduction in the case fatality ratio in the elderly? Or was the reduction in the case fatality ratio in the elderly different in regions that use more or less ivermectin? This is the question we need to solve. So here I'm comparing different periods of time before and after the increase in the use of ivermectin. So, and if the increase impacted the case fatality ratio. And 8 weeks before and after the change in the use of ivermectin. So the first table, this one, the first table shows the entire population of the country, 50 million people. So you can see that before the intervention, here, before intervention, case fatality ratio was pretty much the same every period. 4.5, 4.7, 4.8, pretty much the same. But if you look at after, it was a decreasing 4.1, 3.9, 3.8, 3.7. And yeah, so comparing the periods before and after, the difference are important. 0.38, 0.83, 1.01, and 0.109. And the difference are statistical significant. See, p-values, this is 1 in 1,000, and this is just almost 0. Very close to 0. So let's look at people over 60. If you look at people over 60, you can see the same behavior, the same drop before and after. If you look at the case fatality ratio before, 2 weeks before, 4 weeks before, 8 weeks before, 6 weeks before, or 8 weeks before, there is not a difference in the case fatality ratio. But if you look at the after, it's different and it's decreasing. The difference is bigger than the difference in the entire population, and the values, the difference are statistical significant, and the p-values are extremely, extremely, extremely close to 0. So now look at the population over 80, same result, a noticeable drop in case fatality ratio, and a difference that is statistically significant with a very, very, very small p-value. It's compelling, right? So now let's take a look at the performance of group of states split by ivermectin per capita sales. I selected states with the highest sales per capita and the states with the lowest sales per capita. I made 2 groups, each group with 10 million people. So over 40% of the country's entire population is represented here. And the difference in sales per capita is very important. It's like 8 times more ivermectin use in the group A than in the group B. So let's look at the group A. This is the all age group and the people over 80. 2 weeks, 4 weeks, 6 weeks, and 8 weeks before and after. Big differences in the all age group, differences statistical significant, and the people over 80, even bigger differences and the same p-value, very, 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 very close to 0. So let's see what happened in the group B. So in the group B, where the states use small amounts of ivermectin, there is no drop in case fatality ratio. Not in the group with younger population or in the group of the population over 80. And the difference are not statistical significant. The p-values are from 0.21 to 0.67. And finally, look at the group A, this blue line, with a dramatic drop in case fatality ratio. And the group B is stable. This is each point is a group of two weeks. Mexico, how a test and treat strategy is changing COVID-19 figures. So on January 22nd, the head health official in Mexico City, Olivia Lopez, announced in a press conference that they had been using ivermectin to treat COVID patients since December 29, 2020. She confirmed the use of ivermectin 1 week later. Also, two different health officials, as well as the head of the IMSS, Instituto Mexicano del Seguro Social, confirmed that they were using ivermectin too. I checked public purchases databases in Mexico to confirm myself. And as you can see in this table, ivermectin purchases increased noticeable from the last week of December. And the purchases in 2020 were just few. These public announcements made people more aware of ivermectin, as you can see in this Google graph trend. This January 22nd, the peak. And it's also important to know that ivermectin costs around $7 in Mexico, and you don't need a prescription to buy it. So looking at the test and treat program results, you can see an impressive drop in cases here, and an even more impressive drop in deaths. The blue line represents people who tested positive, and the orange people who tested negative. So because they are only using ivermectin to treat those who test positive, you can see that the drop is dramatic in the people tested positive, but not in the people tested negative. Case fatality ratio is also showing an improvement, as you can see here. People infected within the first 3 months of 2020 have lower case fatality ratios than the expected values that could be provided here. And right now, the positivity rate is the lowest since May 2020, from almost 50% all the time to less than 20%, and it's improving. You can see it, beginning of this in January, when they started the program. And if you look at the hospital capacity, the numbers are really good. There isn't a state with more than 30% occupancy in beds. The highest occupancy is Puebla with 27%. There aren't states with more than 4% occupancy in hospital beds with ventilator. The highest is Chihuahua with 36%. And there are only 2 states with the ICU occupancy higher than 50%. The rest of the country is like 20, 10%, 30%. Now look at excess deaths. In Mexico City, the first week of April here, there was a 6% rate of excess deaths, 6%. And the mid-January was 280. That's a mind-blowing drop without the strict lockdown and in the time of new variants. And the excess deaths in the entire country is also disappearing. The first week of March, excess deaths in the entire country, excluding Mexico City and Mexico State, were only 6%. I'm pretty sure right now they have negative values. Yes, negative excess mortality, fewer deaths than was expected or than the previous years. Like Chiapas. Chiapas started using ivermectin in July 2020, and since then, they have between 20 and 40% fewer deaths than the historical values. Slovakia, results in a European country open to treating COVID-19 with ivermectin. Slovakia approved the use of ivermectin at the end of January, but the drug has only been widely available from March. The interest in ivermectin grew the week the drug was more available. Comparing the interest in ivermectin against the interest in the COVID vaccine, yeah, it's noticeable that during this week, there were eight times more search about ivermectin than search about the vaccine. And if you look at the global searches, the proportion is quite the opposite. Cases have been sharply dropping since the end of February. Both cases detected by the AG test or the PCR. And at the end of February, they were seeing over 5,600 cases per day. And right now, cases are about 1,300, a 75% reduction. So maybe it's because they are testing less. So let's look at testing. If you look at the positivity rate, right now, the positivity rate in Slovakia is 0.5%. And in January, it was similar to that of its neighbor countries. So it wasn't different in January. So look at hospitalizations. Hospitalized patients also are decreasing from almost 4,000 patients in hospitals at the end of February. The number has dropped to 1,500. And the numbers are decreasing every day. This is the last 3 days. Look at the numbers. 80 less people in hospitals, 90 less people in hospitals. And it's happening the same in ventilators or people in ICU, also decreasing every day. Let's look at fatality. Fatality daily count is showing exactly the same pattern. From 105 deaths per day at the end of February to 15 2 days ago. It's a reduction in deaths of 7-fold in less than 2 months. But recently, the data reported doesn't match. It's very important to clarify that there is a mismatch in the daily deaths report. Lately, there has been a big difference between the daily public death report and the official database. Looking at the day of the deaths, the blue line, there is a drop. But looking at the day of the report, there isn't a drop. So the deaths are pretty much the same. This is every point is a week. So day of deaths report is dropping, but day of the official report is not dropping. So who's right? So when they update the reports, they update 3 things. First, they update the registers to add more information. For example, the gender or the place where they die or the region. The second is like normal updates. They update new data. So this is the updates from April the 9th. So you have the same day, the previous day, like recent dates. And the third is all data. And this is what is happening. This is data from January, as you can see here. So adding all registers, they are adding very old registers in the daily report. So what is happening now is that they are adding this huge amount of old registers. They are including people who died in January and February, and they are showing them as numbers of April. So I checked this with the official in charge in Slovakia, and he confirmed that the coroner's office have received many reports from January and February. So here is more clear how the new data is affecting the curves. New registers are mostly deaths happening before March. See, this is the previous report, and this is the new report. This is date of deaths, and this is the report. So they are reporting the cases that happened in February, in April. And finally, as a confirmation, comparing the cumulative deaths in the official report and the database with the day of deaths, day of death has almost 200 more registers. So it's even more accurate, as you can see. This is the report that's showing the like more than 60 deaths per day in the last week. And this is the report showing that recently there are like 15 people dying on it. And they have more registers than this one. So I think it's clear. So what is happening now in Slovakia? Slovakia is opening shops, is relaxing its quarantine, shops, gyms are reopening, and life is getting back to normal. Good for them. Czech Republic results in another European country open to treating COVID-19 with ivermectin. So Czech Republic approved the use of ivermectin the 3rd of March. So yeah, over here. The interest in ivermectin grew in the same week of the approval, as you can see here. The interest in ivermectin against the interest in COVID vaccine was 6 times higher this week. And if you compare with the UK, it's quite the opposite. So cases have been sharply dropping right after the approval. You can see here. From 12,000 patients with COVID or new cases per day at the end of February or first week of March, they have now 2,600, 78 reduction in cases. Is it because of testing? No. Right now, the positivity rate in Czech Republic is only 2%. And after the approval, was like any other country around them. Right now, they have better positivity rate than Germany, than Hungary, than Poland. So hospitalizations, the total number of people with COVID in hospitals is also decreasing. From 9,100 people in hospitals in March 15, the number has dropped to less than 4,000 people in hospitals. And the numbers, as you can see in the graph, are going down every day. Patients in the ICU, same. The total number of COVID hospitalized patients in the ICU are also decreasing from over 2,000 at the beginning of March. Now there are only like between 800 and 900 patients in the ICU. And the numbers are decreasing every day. Deaths, fatality count is showing the same dramatic drop from 215 deaths per day at the mid of March to 75. And it's going down. So maybe deaths are going down because of vaccines. They have vaccinated everyone older than 70. So maybe in the younger population, there is no drop. So let's look at the deaths in population younger than 70. Is the same. Is the same drop than the drop in the entire population. So what is happening now in Czech Republic? Last week, the last update, Czech Prime Minister says relaxation of more restrictions possible this month. So this month is next week. Good for them. So what about India? I will publish a complete analysis soon at Real-Side News. Thank you.
Juan, what an awesome data processing and sharing. This was mind-blowing. So of course, being doctors, we talk about the drug and side effects and the usage, but have never seen the data to be looked at in this detail and with this precision. So thank you very much for doing this work. I really wish that we could actually have you one-on-one as well for the audience and talk more about the data. So tell me this, the thing that is very curious for me is this data presented to authorities and medical leadership organizations? What are the reactions? Have you done that?
I haven't presented directly to the like different audiences, like policymakers, but the FLCCC is using this data to show to different people, and what they said is when they present the clinical trials, some response is maybe there is some co-founders or it's a small test or like something else, but when they present the data, there is like no response. This is because you can't say anything against this. What is the reason? So I've been seeing this data since May last year in Peru, and in this study in Peru, I checked 10 different co-founders, and none of them were like the reason of the drop. And if you look at now, they have this drop, the dramatic drop in August, September last year, and they stopped using ivermectin, and they have now like at almost 300% excess deaths every day since the beginning of February. So it's like 3 months with this huge amount of excess deaths. But
so if I can loop in Dr. Lawrie here as well. Dr. Lawrie, the data that Juan has, is Bird Group working with that data as well to further, so you have the data for evidences?
In actual fact, in February, so after we conducted our systematic review, we included our review in an evidence to decision framework, which is the standard way that WHO presents evidence to their guideline development panels. And in that, we included a lot of Juan's work, which was, it's enormously powerful. So we had the data up until, I think it was the 20th of February when we held the meeting. And the data that Juan had at that point was for Peru and Brazil and India. So this new data is really amazing.
Got it. So one more question to Juan. I'm seeing this question here in the questions tab as well. And for the audience, please, if you have a question, please put that in Q&A. It is easier to curate it from there compared to from the chat. So Juan, another question, and you touched on that for the India and Brazil. So you said that the data is coming soon. What do you see? Can we get some sneak peek of what you are looking at?
Okay, Brazil I'm amazed with the press that is like looking always at the wrong direction. So right now, Brazil is kind of controlling the pandemic. If you look at the official data of the hospitals reporting people with like just symptoms, it's dropping in every single state. So this is Brazil. And also in Manaus, they started using ivermectin at the middle of January, and 2 or 3 or 4 weeks later, they have normal amounts of deaths. And why? It's not possible to like just the virus just decided to go away and don't like stop infecting people. No, it's because they are training people. And in India, what I'm seeing is that they started this new outbreak in Mumbai. They never stop cases in Mumbai, and they started vaccinating too. And there is now some like there's information about this new like double mutant variant. It's a variant with 2 different spikes, and this is probably the reason. And what happened in Mumbai is they have this huge outbreak. People are more interested right now in remdesivir than ivermectin. There are like almost twice more searches about remdesivir than ivermectin. And in Mumbai, they started a lockdown. So people working from other states in Mumbai, they just moved to the normal places. So there was a huge amount of people moving in the middle of the pandemic, in the middle of the break, from Mumbai to Lucknow, the capital of Uttar Pradesh. So they received this huge amount of people infected, and they've been trying to control the pandemic. And it's amazing how the press is just looking at what they want to show. If you look at the numbers in Uttar Pradesh is at the population of Brazil, and they have been reporting less than 200 deaths per day in the last 5 days. 200 is, if you look, is like a 5% increase in the excess deaths, only 5%. And this is under control, kind of under control. And in the whole state of 230 million people, they have 200 deaths. And in Delhi,
interesting,
they have only 50 million and almost double the deaths per day.
Very interesting. So I think, Juan, we're going to follow you and your data and Bird Group, and we'll continue to see what is going on. A couple of questions here in the question window. One is from Mayor Hughes. He says, how does the data in Slovakia and Czech Republic compare to the seasonal drop in cases and deaths seen in the UK without widespread ivermectin use?
I've seen this. I think that it's a very important value to track is the positivity rate, and I'm seeing the same increase or decrease in positivity rate in the UK than I'm seeing the same in places with a mass use of ivermectin, like Slovakia or Czech Republic. I'm seeing the same in Panama, and it's the same in Israel too.
Got it. So one more interesting question here is the vaccine versus ivermectin. And again, we are not sitting here to compare vaccines and ivermectin, but the question is Czech Republic and Slovakia, is the drop in the cases because of vaccines or is it ivermectin? Do you know, have you processed that data? So this is Jeffrey Taylor.
The vaccination in those countries are not the same as in Israel or the UK. It's like probably 10 or 15% of the population with vaccine. So I don't think this drop is because of vaccination.
Got it. One more question. by Ingrid Landman. Great talk, thank you. Have you looked at any data from Zimbabwe or South Africa who are using this drug?
It's the same. It's the same. It's yeah. When any country started using ivermectin, like seriously, there is a drop. You can see this amazing drop in Zimbabwe. You can see this amazing drop in South Africa. It's happening now in Philippines. Is in Central America. Central America, they have been using ivermectin since like early days. And if you look at the number of cases are fewer than any other place. Even the president of Guatemala, he was in a talk with other presidents of Latin America, and he was saying we started using ivermectin in June or July. We authorized like pharmacies to make their own ivermectin, and his brother saying we have the lowest drop in the economy numbers than any other country in Latin America because it's working. He even give the prescription to people in the audience.
Very interesting. Thank you very much, Juan. Let me just see if, so Dr. Lawrie, do you have any question that you curated or that is in your mind for Juan before we?
No, I haven't, but I would urge the audience who are fascinated with this work to read Juan's papers on Peru, because Peru had been using ivermectin since May last year, and they had massive drops, and then there was a change in policy, wasn't there? And Juan shows us very clearly in the paper the effect of a change in policy where ivermectin then became restricted and the excess deaths went up. So I hope people will look at Juan's work and reference it.
Excellent. So Juan, thank you very much once more. I think that we are going to continue to look at the data that you're presenting. It is a very powerful weapon that is needed to look at the data itself and save humanity. So audience, once again, thank you very much for your for listening in, for learning with us. We are now going to move to our next presenter. If I can have the slide for Andrew Bryant. So just quickly, so while Andrew is getting ready and while we have the slide up, Andrew Bryant, I'm just going to...
Biostatistician and systematic reviewer. My main focus
Andrew,
is obviously...
Yes. So thank you very much, Andrew. So Andrew is ready, as you can tell. Andrew Bryant is from the Newcastle University or affiliated with Newcastle University. He is a biostatistics and systematic reviewer. His focus is on biostatistics with experience in clinical trials and systemic review methodology. A vast number of systemic reviews and study publications, main focus in gynecological cancer and currently in COVID research. So Andrew, welcome. Thank you very much for your presentation and your time. Let's listen in.
The most important criteria for risk of bias for the primary outcome, which was all-cause mortality, it was deemed that blinding was not too important for deaths, which is a fair assumption in this case. The BIRD and WHO differ in their interpretation about the immediate implementation of ivermectin. So it's a case of the granular versus the pragmatic reporting aside, is more evidence actually needed? So in essence, who is making the right call at this stage? So in terms of ongoing trials, more evidence will be available in the form of around 40 plus ongoing trials, many of which are reporting death as an outcome. Ivermectin is also shown very promising results for prophylaxis, but the main focus of this presentation will be on mortality, because that is obviously a vitally important outcome given the death tolls so far during the pandemic. With this in mind, one may argue whether we really need to wait for the results of these ongoing trials before taking any action. So in the updated systematic review by myself, Tess Lawrie and the rest of the team, there were 15 included trials in the recently updated meta-analysis of ivermectin versus control for all-cause mortality. This analysis included a total of 2,438 trial participants. The core analysis was conducted in RevMan version 5.4.1. The results were robust to the use of outside software that conducted sensitivity analyses that used different continuity corrections for handling zero events. That is, to ensure the trials with one or both arms that did not report a death in their trial are acknowledged in the meta-analyses. And the results were robust to a number of sensitivity and subgroup analyses, as alluded to earlier, and available in the preprint systematic review, which has not yet been updated online and hopefully will be published in a peer-reviewed journal very soon. So here is the forest plot for the meta-analysis in RevMan, showing a statistically significant result in favour of ivermectin versus control for mortality, with on average a 62% reduction in the risk of death. So now I'm going to talk about the concept of a trial sequential analysis, and work carried out here is based on the guidelines of the Copenhagen Clinical Trials Unit, which provide excellent guidance on this analysis. And I'm just reading this directly from their website. So when they explain further information about a trial sequential analysis, they explain that nowadays meta-analyses are typically updated every 1 to 3 years, and this is the case in Cochrane reviews, as data from new clinical trials emerge. Repeated updating of meta-analyses force authors to repeatedly employ the same statistical hypothesis testing on accumulating meta-analysis data. This conduct has long been known to inflate the risk of falsely inferring a statistically significant difference between two interventions under investigation. Similarly, repeated statistical hypothesis testing also inflates the risk of inferring no difference exists between two interventions, when the truth is that there is a difference. So in the clinical trials, where interim analyses, so interim hypothesis tests, are performed over the accumulation of patients, so this is a scenario akin to meta-analysis updates over the accumulation of trials, advanced sequential hypothesis testing techniques have long been used to control the risks of false statistical inferences. Empirical studies suggest that such sequential hypothesis testing techniques are equally effective in controlling the risks of false inferences in meta-analyses. So essentially the trial sequential analysis setting in meta-analyses mirrors its primary counterpart. So some positive meta-analytic findings could be due to some random error or play of chance rather than due to some underlying true intervention effect. In a meta-analysis, it is important to minimize the risk of making a false positive or false negative conclusion. So that is, there's a trade-off between the risk of observing a false positive result, known as a type 1 error, and the risk of observing a false negative result, which is known as a type 2 error. In conventional meta-analysis methods, such as most reported in the literature and conducted by review teams, do not take into account the amount of available evidence. So a trial sequential analysis uses methodology developed for repeated significance testing in randomized controlled trials. For example, use of statistical monitoring boundaries. These monitoring boundaries can be used to further contextualize the original meta-analysis and enhance our certainty around its conclusions. The analyses below use the O'Brien-Fleming alpha spending function to monitor these boundaries. In summary, a trial sequential analysis can provide a required information size, that is, how many participants in the meta-analysis is enough. This information size is therefore a threshold for a statistically significant treatment effect, or, in terms of fertility, if there is no significant difference between the treatment arms. And empirical evidence suggests that the information size considerations and adjusted significance thresholds may help to eliminate early false positive findings due to imprecision and repeated significance testing in meta-analyses. So some assumptions of a trial sequential analysis. So alpha, the type 1 error rate, was assumed 5%. Beta, the type 2 error rate at 10%. Power of the test, which is derived from 1 minus beta, was at 90%. Continuity correction for 0 events was at 0.01. The control death rate was 7.8%, and this was obtained from the meta-analysis and was consistent with other hospitalised rates reported in the literature. The relative risk reduction of death was 62% in the core meta-analysis. A model-based heterogeneity correction was used, and this is known as diversity and denoted as d squared. The Dissimonian Lord random effects model was used, and further random effects sensitivity analyses using the Sadiq-Jonkman and the Biggerstaff Tweedy models were used. Okay, so the results of the DL method and the trial sequential analysis here. So the DL method is a between trial variance estimator, and it's used most commonly in meta-analyses in practice, and it's the only option available in Cochrane's RevMan 5 software. I'll explain on the next slide what this plot means. Okay, so here the statistical monitoring boundary uses the O'Brien-Fleming alpha spending function, and this is essentially an exponentially increasing function where it produces a more conservative boundary at the early stages, where only a limited amount of data may have been accumulated, as you can see, and then more lenient boundaries are permitted as more data are accumulated. And the O'Brien-Fleming boundaries have various other desirable properties too, which I'll not get into here. Here you can see the fertility boundary of no, which would state no significant difference. Each point here is each study in the meta-analysis. This is represented by the Z curve, where every time a meta-analysis is updated, a new Z value is calculated, and these are plotted with respect to the accumulated information. As we can see here, the required information size was calculated at 1,810. So you can clearly see here that ivermectin is statistically significantly superior to the control intervention, and actually in this case too many trials have been conducted. Now here is the using the trial sequential analysis for the DL method, excluding the Fonseca 2021 trial, because it was a source of heterogeneity. So by drastically reducing the d squared value, as you can see, the results are more resounding here. So here is a sensitivity analysis using another random effects approach, and this is the BT method described earlier. Also excluding the trial, which is a source of high or substantial So here is another sensitivity analysis that uses a random effects method, and this is the SJ estimator, which may overestimate the between trial variance in a meta-analysis, which has mild heterogeneity, thus producing artificially wide confidence intervals. This sensitivity analysis suggests the results of the ongoing trials will be needed to confirm the results of the meta-analysis, but at this interim stage I wouldn't be too worried, and there is no suggestion of futility here. So what does this all suggest? Well, certainly from the DL and the BT random effects models, it suggests that the required information size may have already been met. The more conservative SJ model suggests that the results of the ongoing trials will be important and will add to the accumulation, and the required information size may be met. Certainly no suggestion of futility, and this model is very dependent on the diversity, which was quite high, and is a more conservative approach. I think what we can take from these trial sequential analyses is we can add it as an extra dimension to the certainty of the evidence judgments using grade, and this feeds into the next section on the next slide that I'll talk about. So what is the certainty of the evidence? Well, the certainty of the evidence in the updated meta-analysis for mortality prior to the conduct of the trial sequential analysis was moderate. The trial sequential analysis seems to consolidate the findings and the confidence in the certainty of the evidence judgments. So I think it's just added an extra layer to the certainty of evidence, and it gives us more confidence in that arriving at that decision, that judgment. So conclusions. The trial sequential analysis sensitivity analyses, even with the inclusion of the Fonseca trial, at the very least, do not suggest futility. When a meta-analysis is subjected to repeated statistical evaluation, there is an exaggerated risk that the naive confidence intervals will yield spurious inferences. In my opinion, this criticism can certainly be directed at living reviews, which do not make any adjustment or any attempt at adjustment for repeated updating of results. Results of ongoing trials are expected in the future, some in the very near future potentially, but is the delay and potential implementation in more countries really justified? Should the well-established safety profile of ivermectin in its primary use and in the meta-analysis of COVID-19 trials fast-track its more widespread use? I believe, as many do, that low and middle income countries should get more recognition for conducting trials. Given the number of ongoing trials, should the focus in a trial setting for ivermectin now be in long COVID? The pragmatic meta-analytic results potentially suggest that further treatment trials with a placebo control are unethical. So many thanks for listening to the presentation. I would like to thank various other people that's not listed here, but the Bird Steering Group and the Bird members and everybody associated with the group. I'd also like to thank Christian and his clinical colleagues at the CTU in Copenhagen who specialise in the TSA. Thanks very much.
Andy, thank you so much. What a wonderful presentation. And what made me so happy watching your presentation and analysis is that we are not just talking about here are some trials and we feel confident. We are actually, the Bird group is actually digging deep and looking at the data critically, and then coming back and saying, here is what our confidence level is, here is what we're finding it, and let's continue to move forward. I really, really appreciate the work, and I hope while I was listening to your presentation, I really wanted at that time that some government picks up Bird's work, asks them to expand this work and start helping with ivermectin and moving forward. What a wonderful outcome that could be. But thank you very much, Bird, for continuing with this one. Andy, I have a few questions for you if you are ready.
No problem.
So the first question, when you do the meta-analysis, and especially for the ivermectin, I'm sure that you have been doing this for other drugs and other trials as well. Do you feel that the trials that are participant in ivermectin trial are weaker, as WHO and others say?
Well, I think the WHO, so unfortunately it was a pre-recorded presentation for a number of reasons. First and foremost, probably my accent. So I spoke very slowly and got rid of all the Geordie. But I discussed early on, which I think was missed out, was the granularity of the WHO analyses. It was very sort of piecemeal. It was very spread out, and I think we decided to take the pragmatic approach of ivermectin versus no ivermectin, and then interpret with all the caveats. So when I conduct a systematic review, I'm often asked as a statistician, can you do a meta-analysis? So one of the first considerations is it's the most sensible question, can you? And quite often the statistician isn't the person to answer that if it's not on the grounds of methods. I would certainly look at the methods, and if a clinician says to me on a clinical level, if there's no clinical heterogeneity, I'm always happy to include. So if you want to use the apples and oranges analogy, that's the most common analogy. I'm happy to include apples as apples and interpret accordingly. I'm happy to include oranges and apples and interpret as being healthy fruit. And again, add the caveats that it's not apples. There's a bit of noise with oranges, but if you interpret accordingly, then that's fine. And I would do that with ivermectin. I would do that with any single trial. It doesn't have to be drugs. It can be, complex interventions, behavioral interventions, surgery. It can be absolutely anything. You just sort of strip it down. Does it fit? Answer all the questions. Is the clinical heterogeneity? Is the methodological heterogeneity? Statistical heterogeneity is a post hoc decision. You only observe that after you've made the initial decisions to include the trials, and then to answer your question, in a risk of bias assessment is applied to every single systematic review and in individual trials, and we deemed that most of the trials in the analysis were at low risk of bias. Blinding in terms of some of the other outcomes, so I've only focused on death at the end, because that was the primary outcome. I can do similar analyses for other outcomes, but I think there is probably insufficient evidence or trials in other areas. I think the main sort of evidence base in this systematic review is for death, and everybody would agree that in this setting, because death within 28 days is the sort of major reporting throughout the global world, then that was the one to focus on. That's the most evidence, and that's the critical one. Nobody wants to die. Nobody wants to die of this horrible disease at the moment. So I think that blinding in terms of death for an outcome is not important. It's very important for some of the other outcomes, especially outcomes with subjectivity. But there's no subjectivity in death. It's pretty clear cut. So that's one less issue in these trials. But obviously there's the sequence generation and the allocation of concealment. We were very, very strict on that. So if there was one or two authors thought that we were quite offensive when we pursued getting this judgment, because I think they thought we were being rude because it was from a sort of lower middle income country, and obviously some of the persecution they get, because the conduct is, it's well documented how difficult performing trials and acceptance from the West can be, but we had to get the confirmation. So if there was no confirmation or it was not reported, then we flagged out as high risk of bias. So we had to get the confirmation from the trialists, or it had to be explicitly reported in the methods section that the sequence generation was sort of truly random and it was performed adequately, and the same for the allocation concealment. If it wasn't, then we did sensitivity analyses excluding these studies that we deemed to be at higher risk, and the results in the original review that we did and the original analysis were robust. So we were quite, me as a statistician, so as a biased statistician at Newcastle University, I was satisfied that and factor that into the certainty of evidence judgments.
Very good. Thank you so much. Because I'll do some follow-up questions as well. Dr. Lawrie, if I can loop you in this discussion as well. Uh,
Yeah.
how do you see this? Of course, you're working with Andy as well.
Yes.
How do you see this?
Well, this analysis is very new. Andy's been working on it this week, and I think it's very important. It raises very important ethical questions, especially in light of all the ongoing studies, because there are people still being randomized around the world to ivermectin or placebo, and we have to, given this, the evidence that Andy's presented showing that, in fact, there's enough data. We have enough data, and we can see that ivermectin reduces deaths and prevents deaths. So what should we be doing about these randomized trials, and what chance do we even have of influencing the authorities to say, these trials should be stopped? So I think it's really important that we think about what we can use, how we can get this. Sorry, I'm not making myself clear, but how we can influence the authorities and make them aware that there are enough data, and we need to actually call in all those data that are out there in existing trials and say that's enough now. People should get ivermectin.
Excellent. So I'm going to ask one more question that Andy and Dr. Lawrie, if you both can, whoever, let's start with Andy. And please, you can pass on this question. I don't mean to be too probing, but I want to understand this. If Bird Group can come up with the meta-analysis, and the first question to you, that I hope that you are removing the biases that should be removed. Why did WHO's analysis not look at the same things as you did? Are you looking at, do you have a bias here? Or did they just cherry pick what they wanted to come up with? What happened? They looked at the same things, although they looked at a smaller set. Why did they look at the smaller set? Why are you looking at a broader set? What's going on? So, Andy, can you please help us with this?
Okay, well, to answer that properly, you would have to speak to WHO. So that would be me, political and the politician answer. But I mean, it's different scope. So I mean, in a systematic review, you sort of a priori set out your inclusion criteria. So we decided to go down a more pragmatic route. So it's maybe more representative of a real world situation, because so ivermectin we're going to accept that it might be with other interventions, but I think it was important to establish the fact that they were unlicensed. So I think if they'd been licensed, then I think that would have been an unacceptable inclusion criteria. But I think if there's, if it was in combination with other unlicensed treatments and things like that, then I think ivermectin versus no ivermectin seems to make more sense. But the WHO will have their reasons for doing it a more piecewise. So I think they're very, very restrictive, and quite often, there's the whole lumping versus splitting in a systematic review. So do you, if you're just looking at a specific intervention, do you strip it down to a very bare level? Is that useful, or do you look at it and lump a little bit more? But I think it's very important to lay down the caveats, whatever you do, and be completely transparent. So I think if the WHO have done it their way and with full transparency, and that's one of the questions leveled at them at the moment, then that's fair enough. I think if you can't justify someone, or you don't have an answer for anything, then you've probably not done it right. So I think you've got, and most things have to be done a priori. So it is acceptable to do things post hoc. So the removal of the Fonseca trial wasn't a post hoc decision in terms of it introduced a higher level of heterogeneity. So we did a sensitivity analysis because the trial was at low risk of bias, and the bias thing to do would be to remove it blindly. So we've we've done a series of analyses that leave the Fonseca trial in, exclude it because there's a robustness in the results, then it's acceptable to report that. I think full transparency is absolutely crucial because, you know, if you're selective, you hide things, and things that are done post hoc aren't labeled as being done post hoc.
Got it.
So we introduced deterioration as an outcome, and we label that as post hoc, even though it's a sensible thing to do because we hadn't specified it a priori. So just to be transparent, we try to play by the book, I guess.
Got it. So, Dr. Lawrie, there are a bunch of questions.
I would just like to say, you know, that we approached the work with complete equipoise in January. We did not know, we had no, you know, conception that it was something that would be beneficial or not. And we designed our protocol with ivermectin versus no ivermectin, and we followed the protocol. And we have no conflicts of interest at all. We don't benefit financially from this. We've actually been working for free, some of us, for several months now on ivermectin, just trying to get more behind us to persuade the authorities. You know, the world authorities are kind of overtaken by these private-public partnerships. So there's a huge private influence. I can't say that this is the reason, but as I've been trying to think things through and to think, why have they taken this approach? Because I consult for them, and I know usually we base the work on Cochrane reviews, and they're rigorous, and the evidence to decision frameworks are rigorous. We wouldn't be excluding randomized trials like they are. So I have a lot of questions about this, and you know, they have a program called the ACT Accelerator, which is a $38 billion program that they're raising money from countries to develop novel treatments and vaccines and health systems and so on. And my concern is that that this program is a barrier to accepting a cheap treatment like ivermectin. But it's something I would like clarification on, and that's why I'm calling for more transparency and accountability in terms of the guideline process for ivermectin, because it seems like they have not taken into account the body of evidence that they should have done. Sorry, I know I'm pushing time-wise.
This is exactly what I was trying to understand. And thank you very much both for clarifying this, that I feel that looking at Bird's work, we can trust it. We can say this is the right work. They've been inclusive. They've been very, very, very cautious. And here we have WHO, which have cherry picked. So thank you very much for clarifying that. A couple of more questions. I know that we are at time as well for the next one. One question is from Fahmida Sheikh. She says, would it be possible to do a similar review for ivermectin as a prophylaxis, or is there need for further studies?
We did include ivermectin as a prophylaxis in our review, and as I presented earlier, there were 3 trials that we included. There weren't, most of the body of evidence on prophylaxis comes from large observational trials and studies. So there's a huge body of evidence on its effectiveness, its efficacy in prophylaxis, but only 3 randomized trials at this stage.
Got it. One more question from Merili Fanas. They say that, is the Bird group sharing its information with the international lawyers?
We have been approached by many legal groups around the world asking if our evidence is available, you know, asking how we can support them. So, and we are happy to do so. Got it.
Cool. So thank you very much, Andy. Thank you very much for such a beautiful presentation, and for your work, for your diligence. I can only imagine how much data you have to sift through to figure out the results. And Dr. Lawrie, thank you very much as well. Let's move to our next presenter. So we have, for our next presenter for today, we have Dr. David Chesler. He is from internal medicine physician, private practice, Charlottesville Family Medicine, 1980 till present. Diplomat of American Board of Internal Medicine, board certified in geriatric medicine. So Dr. David, welcome. Thank you very much for your insights. Thank you very much for your time. Let's start.
Good morning, I'm Dr. David Chesler. I'm delighted to be able to share with you my experience in treating older patients with COVID-19 in the elder care setting. I've been in practice of internal medicine and geriatrics since 1980, or maybe a couple years before that, in Charlottesville, Virginia. Charlottesville's about a 2-hour drive south of Washington, an hour west of Richmond. It's the home of the University of Virginia and the home of Thomas Jefferson, where he was born and lived. He was the 3rd president of the United States and the author of the Declaration of Independence. Although I have a healthy outpatient clinic, I also have, with the help of nurse practitioners and physician assistants, care for a large number of nursing home residents and assisted living residents in different facilities. Now, I have to admit that last spring was a pretty scary time, probably for all of us. Scary enough that my daughters were insisting that I retire and go find a cave to live in for a while. But that didn't sound too exciting. It was clear that the nursing homes were experiencing large epidemics of COVID, leading to high mortality rates. By April, we had several nursing homes in the central Virginia area who had had mortality rates close to 30%. Following the news and literature, it appeared to me that the focus of the medical community, especially here in the United States, was only how to treat those individuals affected with COVID who had gotten sick enough to get into the hospital. It was a difficult time. It was hard to get PPE. It was very hard to find testing. I didn't feel that that was the best thing we could do for our nursing home population. I thought that some kind of early treatment that might help keep them from getting so sick that they would end up in the hospital and then lose their lives was something that we could achieve. Now, there have been early reports of outpatient treatment with hydroxychloroquine and azithromycin, but there was also some concerns about potential cardiac toxicities. Then I read about the in vitro study out of Australia by Tally, where COVID-infected cells in culture showed a rapid clearance with the use of ivermectin. Now, as it turned out, I'd had a lot of experience using ivermectin in some really difficult to manage scabies outbreaks in the nursing home setting. And I found it to be extremely safe medicine, essentially no side effects. So what I set out to do was put together a regimen that, first of all, I would not expect it to do any harm, and at least would have a basis in theory that would help COVID-infected patients. You can go to the first slide, please. But then it happened. One of the nursing homes I was covering was infected with COVID. Next slide. So what we did was, let me get where I can see these slides too. The homes that I covered included in this study, 2 assisted livings and 5 nursing homes. One was an intermediate care, which generally did not do any IV fluids. And then there were 4 skilled nursing home facilities. Altogether, we're dealing with 513 high-risk residents, 309 PCR confirmed cases, and what I used was a multi-drug approach. Next slide, please. And this was a regimen that I came up with. vitamin D3, 2,000 units, vitamin C, 1,000, and zinc, 100 milligrams. And the plan was to do this for 3 weeks. I added to that enoxaparin, 40 milligrams sub-Q for 3 weeks. And this is prophylactic dosing. And then to that, I added ivermectin, 12 milligrams a day on days 1 and 8. And that was the same dosing that I was used to using in the nursing home with the scabies. And it proved to be safe. And like I said, no harm was our goal. And also doxycycline, 100 milligrams twice a day for 10 days. And that was in facilities 2 through 7. Now the numbers have to do with the order in which they developed. It turned out I never had more than 1 facility with the COVID outbreak at one time. The only difference here was that in the very first facility, we used azithromycin, 500 milligrams daily for 7 days. So we sort of took the hydroxychloroquine azithromycin regimen that some people were promoting, got rid of the hydroxychloroquine, and just added ivermectin to that. Next slide, please. So let's look at the first facility. This was an intermediate care. Like I said, they generally did not use IV fluids there. It was a 30-bed facility, part of a life care community. We ended up with 100% positivity. The average age, 87.7 years. And I divided it into 2 groups, early and late. And this had to do with how we were able to test these patients. In the early group, there were 6 patients. We really had to scrounge around to find testing kits. One individual was an end-stage dementia with failure to thrive, and he expired. His goals of care were to not use IV fluids, and we respected that. It was really 8 or 9 days before we were able to test anybody else. I was convinced that the facility was going to have a lot of COVID because one of the women in the first group was a very ambulatory, though demented individual. And I kind of assumed she was carrying COVID around to everybody before we were able to find out that she had it. And that proved to be the case. Now in that late group, and the other thing I would mention was that I did not want to start treatment until I knew that we had a confirmed case. Now there were 19 patients that received the regimen, and there were 5 patients who didn't, and these were patients for whom I was not the attending physician. One individual was a 104-year-old lady that had a stroke and passed on. In the non-treatment group, there was 1 individual who passed away. And in the 19, including the stroke patient, there were 3 others. And these were all failure to thrive, end-stage dementia, dependent on all their ADLs. And the families did not want us to use IV fluids. I had talked the facility into using Clysis if it became appropriate, but we didn't use it. Next slide. So, but the lessons I learned in this first facility was that testing early meant earlier treatment and better results. The only person that I had sent to the hospital in that early group was someone who developed profuse diarrhea, and he ended up in the ICU for about 8 days and came back to us, and he's still doing fine. And I thought the hardest thing to tackle was the anorexia, which usually started coming on in the 2nd week. And nursing had to really work hard to encourage people to eat and drink and to keep them hydrated. I might add that nobody developed acute hypoxic respiratory failure. A number of people used some low flow oxygen, but that was all. Next slide. The first facility was, the infection started in late April. Facility number 2 showed up in June of 2020. This was an assisted living facility. There were 57 patients. We ended up with 63.2% positivity. There was an average age of 80.7 years. The first individual, the index case, was someone we thought was probably uroseptic. She was obviously very ill. We sent her to the emergency room, and there she tested positive for COVID. So now we knew there was COVID in the building. The first thing that I did was I placed the entire facility on vitamins and zinc. Next slide. Let's go to the next slide, please. So all in all, we had 36 positives. There were 4 deaths early on. None of these people were able to have gotten any treatment at all, actually. 2 of these ended up on respirators, and both subsequently expired. One was being the index case. And there were 2 others who were already at the end of their life in hospice, and they passed on before they could get any kind of treatment. You have to remember that in all these facilities, you don't have in-house pharmacies. Plus, the pharmacies weren't all geared up to have ivermectin. So there was often a delay of a day or 2 before we could get the ivermectin in after I ordered it. All of the 32 patients who were treated survived. We did have testing done weekly. Things were getting a little better on that score. And here I'd switched over to the doxycycline. That and the ivermectin and enoxaparin were started as soon as a patient became positive. Over the course of several weeks, a few people did get dexamethasone when their SAT started to drop or get wheezy. All in all, good experience. Next slide. The next facility, I'm going to skip 3 and we're going to come back to it. Number 4 was a small assisted living facility. There were 15 patients. 10 of these were positive, which gave us a 66.7% positivity, average age of 84.7. There were 8 survivors. 2 of the patients who died were really end stage, end of life, failure to thrive, dementia on hospice. And they'd actually quit eating about 2 weeks before COVID got in the building. And they expired. Whether they died with COVID or because of COVID, of course we won't know, but I think it was really that they died with it. Next slide. The next facility, number 5, was a skilled nursing facility. It's one of the ones that I'm actual medical director of. We had 92 patients in the facility. We had a 29.3% positivity. The average age was 78.2. So we had 27 positives. The first person in the facility to get COVID was actually a staff member. And at that point, we started the ivermectin, excuse me, the 2 vitamins and zinc, and then waited for the PCR test to be done. So there were a total of 27 positives. 24 were my patients, and so they all received the regimen. There were no deaths. And there were 3 who were taken care of by another physician, and they did not have any of theirs die, but 1 was on ECMO for a good while in the hospital. Next facility, next slide, please. This is number 6, 90 patients. Again, a SNF, and again, I'm medical director at this facility. 27.8% positivity. I think we did a really good job in both of these facilities in containing the outbreak. The average age was 81.2 years. We had 25 positives, all of whom who received the regimen. Again, as soon as there was word that a staff member had, because it always seemed to be the staff, that they were positive, then the whole building was placed on the vitamin C, the vitamin D, and the zinc. We had 23 survive. There were 2 deaths. One was a gentleman who'd been on comfort care for 4 months. He did get the regimen, but we were not permitted to use any IV fluids, and we lost him. And there was one other gentleman who was a brittle diabetic. He was initially doing pretty well. His saturations were all good, and he was found to have expired in his sleep about 3 in the morning. And I suspect it was from COVID. Next slide. So let's get to number 3. This one actually occurred in July. It was this was a facility with 132 patients. There were 90 patients became positive very rapidly. The average age was 77 years. The oldest resident was 106 years old. 3 patients died early before the regimen could ever get started. Next slide. And I'm going to divide it into 2 groups. Myself and one other physician cared for pretty much all the residents in the facility. Now, in my group, I had 58 total patients. There were 39 PCR positives, or 67.2% of the patients, and they were all treated with the regimen. In that group, I had 2 deaths. One was a 100-year-old fellow with renal failure, and one was a fairly demented individual, not on hospice, but when she got into the 2nd week and the anorexia set in, she wouldn't eat. It was hard to get her to drink anything, and the family declined to give her any IV fluid support. This gave us a mortality rate of 5.1. The 106-year-old required IVs for about 4 days, and by that time she was able to start eating and drinking well, and she continued, and finally, we finally lost her a couple months ago, but she survived COVID. Next slide. Group 2, and I'll refer to this as Dr. A's group, we had 74 total patients. He did, and there were 51 positives for a positivity rate of 68.9%, but he had 17 deaths. Remember, I had 2, so he had 17 deaths, and I'm dividing these into how they were treated. He began using the regimen, and then some other physicians talked him out of using it, declaring that there was no evidence and this was not standard of care. He fell for that. And so after about 4 days, some of the patients that had been started on the regimen were stopped. And then after that time, none were started as they became positive. And partial treatment for most of them consisted of 1 dose of ivermectin and 3 or 4 days of the doxycycline. His mortality rate was 33%. Next slide. There was one other facility, this is the 7th one, and it was kind of like running the marathon and then tripping in the last 100 feet. We were almost to the vaccine, and in late December, COVID entered the building. There were 94 patients in the facility at that time. They ended up with 88 positive cases, the average age being 81 years. There were 93.6% positivity. Next slide. And again, I'm going to divide this into 2 groups. Now, it turns out in this facility, there were 4 providers, myself, who had the majority of the patients, and then 3 others. And one of the providers that I'll refer to as Dr. B followed my regimen. So between us, we had 65 positive cases, all of whom received the regimen. There were 2 deaths. One was an end-stage dementia hospice patient with failure to thrive, and then one was a fellow who, of mine, who had entered the facility initially as a respite from hospice. He had metastatic lung cancer and had already survived a lot longer than we had expected, but we lost him during this time. This gave us a mortality rate of 3%. Group 2 were the 2 other physicians. They had 23 positives, and none were treated with anything other than what I call first aid, which was low flow oxygen as needed, Tylenol, and encouragement. That group had 5 deaths, which gave them a mortality of 21.7. Next slide. So in summary, I had was caring for 513 high-risk residents. There were a total of 309 PCR positive cases in 7 different facilities. The focus was on early treatment. As the months went by, it became easier to get the treatment done, and we could test weekly or even bi-weekly. Although I would admit that in that last case, the last facility, number 7, it became clear that getting into the end of 2020, there had been 16 cases, and I knew it was going to spread throughout most of the facility, which it did. And on New Year's Eve, I made the decision to go ahead and begin the ivermectin and doxycycline and enoxaparin. So I did jump the gun there a little bit. And then when the next round of testing came on January 4th, the numbers just started to pile up. And then the next testing was on January 8th, and then there were further ones down the line. So some patients actually did get the ivermectin and doxycycline started in advance. Next slide. So the 2 facilities with multiple providers sort of created a poor man's control study. There were 229 residents with 181 positive cases, 152 resolved. There were 29 deaths. So if we look at mortality by treatment, those that received the full regimen, 3.8% were lost. If they got the partial regimen, gave us a mortality of 16.7. That, and partial again meant 1 dose of ivermectin and 3 or 4 days of doxycycline. And those who received no ivermectin or doxycycline, 37.3% mortality. And that's my experience. There were a couple of facilities that had some further outbreaks. Facility number 1 and facility number 3. One had 5, one had 6. They all received the regimen, and we had nobody expire. So I'll open it up for questions, and I thank you all for participating in this conference and showing interest in early treatment of COVID, especially with the use of ivermectin. Thank you.
So Dr. Chesler, thank you very much. The thing that I noted, so of course, being a medical doctor, I was also very much interested in seeing the regimen that you were using, but the bravery that you decided to start using it, and then your team started using it, and then the results that we are seeing here, such a wonderful step that you took and saved lives. I have lots of questions here. So let's start one by one and see how far we can go. So first of all, let me go from the questions that are here in the window. Let's start with Merelli Fanos. They say, Dr. Chesler, thank you for having the courage to save your patients. I sincerely hope that your information and that of the other brave physicians will be shared, as is the case in the bird group. So the question for you is, would this be the information that you provided here available somewhere? Is there a protocol that you have developed during this process?
Well, several of the people in the Baird group are working with me to try to get this published. Hasn't been that easy. We were rejected first time, but we've made some changes and we're trying to get it out. Early on in January, I had sent most of the data up to the NIH and never heard anything back from them.
Got it. So one more question from Mike Muldoon. So Dr. Chesler talks about use of ivermectin and vitamins. What vitamins did he use? I heard about vitamin C, vitamin D, and zinc. Are there any other vitamins or supplements that would have helped in healing multivitamins? So did you have a specific regimen with these vitamins?
No, those are the ones I started with and I stayed with them. There were other things that people were starting to use, like famotidine or colchicine. The thing was that the regimen kept working, and I just didn't see any reason to change it. And every time a new facility would get infected, I would worry if the magic was going to work again. And it always seemed to. And the thing that was important to me was that nobody ended up in really bad respiratory failure. I didn't have one person who got the regimen end up on a respirator.
Got it. So this is then leading into this next question. And I'm going to collate two questions here. One question is about your own staff and their prophylaxis. Were you using ivermectin as a prophylaxis, your staff? And I'm going to add one more question here as well, and that is in a similar line. How long can I take ivermectin if I am caring for an infected intubated patient? So they have been using ivermectin 1 tablet 3 days straight, 2 tablets when admitted with the patient in the hospital for 3 days. Should I still continue to take ivermectin? So can you help us with the prophylaxis and approach to that?
Well, my staff and I did not use ivermectin prophylactically. We were fortunate. We were able to have enough PPE to keep ourselves protected. I do know a few people who have been using ivermectin, and they have been taking 12 milligrams on a weekly basis. But in our area in Virginia, there are 2 hospitals, and the 2 hospitals are not at all interested in ivermectin. A few people have we've talked about it, but the corporate structure is such that they don't want to promote it.
Got it. And that is another question as well here, that were you, and there are lots of questions, Lawrie, Dr. Lawrie, you will have to guide me if we should be wrapping up. I think that there is a lot of good information that Dr. Chesler can help with the doctors as well. So may I continue to ask some more questions?
Well, I think we do need to start wrapping up. But what I would like to say to everybody is that we have Dr. Chesler's one of the first clinicians on the program. Tomorrow we have many more clinicians who can also assist with answering questions about dosage and other, more sort of patient-centered questions. So I think if Dr. Chesler is happy to wrap it up, they will take one last question perhaps. And then we'll wrap it up. What do you think, Mobeen?
Perfect. I think that is perfectly fine. So one question that is interesting is I'm going to collate 2 questions here. One is the use of dexamethasone, or did you use inhaled corticosteroids as well? And what was your approach, early use, late use? And the second, I think, is very important, and that is side effects of ivermectin. Did you see any contraindications or side effects?
No, we didn't. There was one person that was on warfarin, and so she stayed on that, didn't use the enoxaparin, and like I do with any new drug, we just start checking the INRs a couple times a week just to make sure that it's not going to have any side effects, because there's the potential with ivermectin, like with other drugs, to enhance the effects of the warfarin. And what was the other?
So one was the side effects, and the other one is the steroid use. Did you use the steroids early on, later on, inhaled, not inhaled? How did you?
We used dexamethasone, and we used 6 milligrams a day for 7 days. And we did that in people whose saturation started to fall, or if they started to get wheezy. There were a number of the patients had COPD as one of their comorbidities, and if they started to wheeze much, then we went right to the dexamethasone.
Got it.
It was just surprising that especially like the second facility, which was an ALF, we had very little respiratory. I think I mentioned that we used dexamethasone only 2 times.
Got it. So Dr. Chesler, thank you very much for your very, very fascinating discussion, because geriatric population is actually at a higher risk, and then be able to work with them with ivermectin and have such wonderful results. That is exceptional. Dr. Lawrie, any comments before I summarize for the day?
No, I'm going to just leave it up to you, Dr. Bean. Thank you.
Cool. So audience, thank you very much for being with us today. This is the last part. Dr. Chesler's discussion was the last part of our discussion today. So I'm just going to quickly summarize the discussions today. One reminder that we would continue our discussion into tomorrow as well. And so same time, but we'll have Dr. Corey, and we'll have Dr. Eli Schwartz and Dr. Hector Carvalho and more. So please make sure that you check in tomorrow and listen in. So the discussion today, I presented with the summary of the functions for ivermectin. These functions, important thing is that there are references to all of those potential functions. I would request you to go look at those studies and those references as well. So there were 5 functions, 4 of them directly that can be very static, where the virus replication is reduced or virus binding with the cell is reduced, which actually exposes the virus to immune system, and immune system can clear it out. And the 5th mechanism is modulating the inflammation. So that is one set of things that we saw. Dr. Lawrie's discussion about the most up-to-date trial data shows that primary and secondary outcomes significantly favor ivermectin for the treatment and prevention of COVID-19. After assessing additional factors such as the equity implications and the low cost and wide availability of the drug, ivermectin should be authorized for use against COVID-19. And this is a very important thing. Given the slow and unequal rollout of the vaccine worldwide, ivermectin is a good bridge to reach global vaccination shortness. This is really, really important, that while we are waiting for the vaccines to become available and then to be available to people, ivermectin is a safety guardrail. It is a bridge towards that. So thank you very much for bringing this point up, Dr. Lawrie. Juan talked about the countries like Mexico, Czech Republic introduced the use of ivermectin against COVID-19 early in 2021 and have experienced sharp drops in cases and fatalities. It was wonderful. It was fascinating to look at those graphs, to say here the approval came or the usage came, and here is the graph that is showing. And we are now waiting for Juan to look at more data from India and Brazil and then come back to us with some more information there. After controlling for a number of factors, Juan concludes that there is only one explanation for these reductions, and that is the wide implementation usage of ivermectin, both in outpatient and in hospital settings. So more data to come. Andrew concludes that the certainty of the evidence in the updated meta-analysis for mortality prior to the conduct of the trial sequential analysis was moderate. Based on this, and even given that the additional results of ongoing trials are expected, he asks why delay implementation of ivermectin for COVID-19 now, given the evidence. And finally, you heard the message from Dr. Chesler that number one, early treatment, and that is a mantra that we all should have, early aggressive treatment, and part of the aggressive treatment is ivermectin. You also saw that with ivermectin, he used azithromycin or doxycycline, or if necessary, dexamethasone as well. So with this, I wanted to share a slide. So if I can have the slide for the BIRD group and our how to reach us, how to follow us, and if some of you would like to support the work as well. So here is, let's spread this word. Here are the hashtags for Twitter to use. And if you wanted to reach out to BIRD Group itself, so BIRD Group UK is the Twitter handle, bird-group.org is the website as well. I'll actually very quickly show you the website, or actually, let's continue here. Can I go to the next slide, please? And if you wanted to help support this work, I think that this work is critical at this time. There are very few organizations, I think I can name them, FLCCC and BIRD here, who are actually on the people side helping and supporting. So if you would like to donate and support their work on the BIRD Group page, so bird-group.org, there is a button, there's a page donate, and you can help support from there as well. I would recommend also to join the mailing list, bird-group.org, and there is a mailing list there. You can use that as well. So with this, thank you very much, everyone. Thank you, BIRD Group, for pulling us all together and educating us. Thank you for every panelist who have done their work so diligently and so thoroughly. Once again, Dr. Lawrie, anything from you before we close? You are muted. Okay, perfect. So thank you very much all, and we would see you tomorrow.